we had less than 20. We thought we also looked at some of the institutions and we saw that there were some that really for like 20 years had not added any equipment, had not recruited staff. Some will have very few staff and they're still doing internship. And we thought that wasn't good for the profession, even for the interns, because you would want to just have a waiver to be able to do internship in an institution without accreditation. But then by the time you finish the internship, you want to get employed. But because there is no accreditation, the institutions are not employing, because whenever you're going for accreditation, they employ just so that they can fulfill the requirements. So looking at the future, thought it's important to improve the quality, but also to ensure that pressure them to be able to recruit. So when the interns leave, at least that to come in. So we insisted that there must be accreditation. But what we did also was to reduce some of the constraints that make institutions not to be able to get the accreditation or request for the accreditations. Number one was reducing by over half the accreditation fees. That was one of the things that we did. Number two, we came up with a policy that private clinics, so not even private hospital, private clinic, all they need to do is just to have an MOU with a hospital that have inpatient. And if they have that, they can be the ones recruiting the interns, and they have that MOU so that what they lack in the clinic, the hospital can make up for that gap. We also did that, but also complained to the Minister of State, Dr. Tunji Alausa. That was about 2 years ago, about the issue of the shortage of places that do internship. And he was one interesting person. He wants to see a problem and quickly put action in solving the problem. So he said, I should write to all hospitals that were not doing internship and ask them that he has mandated them to start internship. He said also write to all hospitals that don't have medical rehabilitation professions departments and ask them that they have been mandated to open departments in those institutions. But of course, we all know the bureaucracy of government. When we wrote, some of the institutions wrote back to say that, well, we don't have the budget. We want to include this in the budget. But if we get a letter formally from ministry, it will help us when we include it in the budget to be able to defend the inclusion in. And I went back to him. He gave us a letter, and we sent that letter to all those that requested for it. And so it's a process, and it will like that. The private clinics, those that wanted to start, reduced even from that half that we reduced it to even half of them, so that they can be able to accommodate the cost and be able to do that. So while we're doing all that, as a committee of registrars, we are pushing to the ministry for centralized posting, central posting. And at some point, the ministry informed us that they were going to present the matter to Federal Executive Council, because whenever you have something like this that's national and that requires funding, that has to go through budget, usually the ministers will take it to Federal Executive Council. If it is approved, Ministry of Budget will now accommodate that in the budget, and they asked us to give all the data that is required. So what's the average cost of paying interns? How many graduates that we produce yearly? How many do we have in the system that have not done their internship? We gathered all the data. We gave them the developed a memo, and the coordinating minister himself said he was going to present it at the Federal Executive Council. So at some point, I remember Dotun is here. I think he and his team, about 3 or 4 of them, came to the board. We sat, discussed how we can be able to make things better, and I took them to the ministry. And we met the Director of Hospital Services, who was in charge of that memo and things that were related to it. And he told us, in fact, he said to me, go and begin to plan for how to implement. talking about the issue of the portal, which now we have already developed, at least to some extent. There's still more information that needs to come in. It needs to be upgraded. And we have done our own part, waiting for the ministry's nod that we can be able to start central. He didn't tell us exactly what the discussion was between the ministry and the Federal Executive Council, but Dotun was there and his team when he told us that they had gone to some extent, that we should start preparing from our own end. So it's when there is central posting that MRTB will be responsible for paying salaries. But if the hospitals are employing, there is no central posting, they employ, they are the ones that give salary. And the mandate of MRTB, it doesn't include this issue of following up to know what salary people are being paid in the institutions. But because there is nobody that will do that in the ministry, we don't have any department or division or rehabilitation. That is why many of the things we take the responsibility. We have already written to the ministry recommending that a department or division should be established for rehabilitation. And when that happens, that's when they will be the ones to be doing many of those things. But at the moment, we are happy to intervene if there are complaints that are brought to us formally, so that we'll be able to see how we can help sort them out. So I think, just like you said, it's evening and there is no time to go through long discussions. I'm going to try as much as possible to just give short answers to the questions that have been given. But if you need more clarifications on issues, feel free to raise them. Thank you.
Thank you so much, Registrar. We really appreciate your concise answer to that question. I would like to raise suggestions, comments, questions from the general public of LFIFCs. If you want to ask anything that has to do with internship, the welfareism of interns, salary, anything that has to do with internship, if you have something to say, to ask, you want to have a comment to raise, please raise your hands up and you can call in order. Count like 1 to 5 so that I can know the number of persons who we want to take for that. In 10 seconds, how do we do that? 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. So, okay, we have 2 hands raised. PT Dotun, over to you. You have the floor. No, then I'm the upper store. Okay, yeah. You have the floor.
Okay. Good evening, everyone. Good evening, Professor Rifai. Name is Dotun. Yeah, so I can confirm a number of the things that the registrar mentioned. Last year, August, we were in Abuja and the registrar took us to the ministry. We paid a visit to some of the key offices related in the internship matter. And he's right, it was given the go-ahead. So I just want to seek a clarification because the truth is, I remember that when he was told to begin the go-ahead, even the registrar was hearing that for the first time, and he later, I remember we stepped out and he explained to us that yes, he's hearing about this go-ahead now, but we were meant to understand like things might not happen so fast. But then we're also given assurances by the ministry, by officers in the ministry, that we're also given assurance that this thing will get done fast. So I think that's just the update I want to ask the registrar if there is any update to that, because it seems like what I am still aware of and or the physio what we are still aware of from a year ago. I just want to confirm that is it that there is no change to that? So that will be for the first one, because we know that centralization will not solve all the problems. Many people make reference to MDCN and house officers being centralized. the truth is, when you actually look into it, it solves a large chunk of the problem, but it doesn't still solve all the problems because even that system is facing certain challenges. But of course, it's a development that we want to be set in motion, and we met a contact person that last year when we went, and I think I called the person towards the end of 20 last year, I believe, when nurses went on strike and they made a circular that the central placements had been approved for them. So based on the information that we had, that it will not just be for nurses alone, it will be for everybody. We're wondering why we had not had that feedback. And I remember I called Prof then too, and he said, "Oh, nothing has been communicated to them. Like this thing is, green light. You can go ahead." So, but when I communicated with that person, he said what was the green light then was that it was on the table for this CBA or something like that. This is collective bargaining thing. It was one of the things that was going to be pushed in that discussion to be discussed. But I also don't know the update on that. We know with Joeso strike and everything, I know all those things were connected. So again, I'm just giving backstory so that everyone can follow on the chain of events. So it would be good to know if there is any change. Do we need to still apply pressure one way or the other, or we should just wait for things to play out? Because it's been like a year, honestly, and that's a lot of time. I know things take time, but it's a lot of time as well. Then, secondly, I know a common issue with internship is how the topic interns welfare, how interns are treated during their placement time. And I remember discussing with Divine Favor. He was telling me how there are no channels for interns to give feedback. Interns are being bullied. I think I even saw some people did research on that. There's workplace bullying. There is the thing where the interns are running the hospitals, basically because there is no supervision. It's supposed to be a period of learning, but there is barely any supervision. And even with that, there is oppression and all that. In different places, we hear different stories. So I know that there is a stakeholders meeting coming up for institutions that train internship. So I don't know if that's one of the things that will be discussed there. If it isn't, I think we would advocate that should come up. And then thirdly, I think on the issues of payment, I think that will come from the associations. I think that pressure will be applied from the associations because they're the ones that should do things like that. But so far, at least in the few engagements that I have presented, especially with NSP, I've not had any with ACAPN. It usually puts that like it's not NSP's work. So maybe some clarification on that would do.
Okay, so I don't know if the coordinator will always ask me to speak, or if after the question I should just go ahead and speak. Just let me know.
Okay, sir. I will always tell you when to
Okay.
come on. I want to see if we can. We have just about 3 hands in case we have likely questions, so they can just give a answer to all of them and so on, instead of answering one by one. Do you understand, sir? Or would you prefer to answer?
That's okay. No. That's okay. I was just trying to let you know that I'm waiting for your guidance on when to speak. So whatever you decide is fine with me.
All right, sir. Thank you so much, sir. We would like to take it in threes so that you can answer in threes together at a time. Thank you. Thank you so much, Dr. Oluwasomi Dotun. Your questions and your concerns have been noted down. Registrar would address them when it comes up. Over to you, Dr. Divine Favor Onyekelu. Please, let's make our questions as short as possible, straight and precise, so that we don't waste time telling stories and all. We have quite a lot to cover tonight, and we don't want to go into late in the midnight. Thank you so much. Over to you, Dr. Divine.
All right, thank you very much. Good evening, everyone. Sorry, transit as well. Good evening, my registrar, bro. Good evening, chairman of the entire Bose. Good evening, my chairman. Good evening, good evening, all my friends. Hope I'm audible, please.
Divine, you are audible, but there's a bit
Am
of
I audible?
It's better now. I think it's better now.
Okay, all right, sorry. Yeah, so I think I'll just elaborate more on what Sotun has already said. The two things that I've always been pushing for, even when I was still the now president, then was centralization of internship, which I also had a conversation with the rep of MRTB during Dr. Kanle's time. So, which we that I knew as of then that they were already pushing for it. So, like Dr. Thompson said, it would be best if at least after 1 year there would have been a more reasonable change on that. So, I appreciate the registrar for the whole effort he has been putting and has been contributing as regards to the progress of our profession. That being said, I over the time emphasis have been paid on the issue of internship allocation, internship placement, and what have you. However, just like the my prof, sir, if you can remember the very first conversation or very first meeting I had with you with other intern reps back then, I think in 2022 or 2023, one of the concerns I raised was the welfareism of interns, physiotherapy interns. And the truth of the matter is that interns are regulated or monitored by the board. So it more often happens that when someone is doing internship, even if the person have an issue or a concern or an abuse, maybe you've seen incidents of sexual harassment, incidents of being abuse of power, which is the word also abuse of power. Also, especially my colleague that was also the major incident happened in Asaba, FMC Asaba back then, whereby he was also downgraded from a to a porter, carrying in and carrying out patients, doing the laundry for the HOD and what have you. I believe that there should be a monitoring kind of a system whereby the board, I had a conversation with you, my prof, earlier on this year as well, which requested we have kind of sort of meetings. So I'll also be expecting a working plan that in future, people that are doing internship will not have to suffer. And even if you are unfortunate to be in such situation, you have people that you can actually reach out to in the board, and the board can react or effectively react on that. So I will appreciate the prof if you can also throw more light on that, or even if possible throw more solutions on this whole. Because I said I sit as a main for our profession, especially the young physiotherapists. So please, just on that, and then I also appreciate you on the whole centralization of internship, and then a way forward on that as well. Thank you very much. I'll reserve my comments for now because I'm on transit. Thank you, sir. Thank you, Oluwa. Please, you have the floor.
Thank you, Dr. Divine. The last person that will speak before Prof react, we have Dr. Iwo Mazimo Alexander. Over to you.
All right, thank you very much, Prof. Can you hear me?
Yes, we can hear you properly.
Oh, my Prof, good evening, sir.
Good evening, sir. Well, anyway, they said young physiotherapist. I know this one is grandpa, but let me
This
listen
one is
to you.
grandpa, yes, but he wants to put a voice in their direction. I want to use this forum to appreciate you so much. The readjustments you made concerning private clinic accreditation for safe practice, I benefited a lot. So I thought maybe a suggestion could come in that direction that will favor internship. Currently, the internship accreditation guidelines and all of that is okay, but I'm thinking we need more centers, especially Northeast. We need more centers, and I know we need more centers across the country. So is there any special thing that could be done so that more centers can come on board, so that more interns can be taken per time, and then this waiting issue will come to an end or reduce to the barest minimum? I don't know if the benchmark could be reduced, maybe pass mark for full accreditation or partial, if there could be a readjustment so that it will favor centers that are not too big. You know, we have big centers, Kano, AKTH, UCH, Lagos, we have big centers. But that does not mean smaller centers cannot come up if they are given a little opportunity that can maybe a little bit. Yeah, so I was just thinking in that direction. I said, since this kind of opportunity is on ground and they're discussing internship, let me just chip it in as a question. It's very likely something would be on ground already. The last time the stakeholders meeting that was held for accreditation of training institute, I even thought hospitals would be part of it, but I realized that it was for academicians mostly. So I was trying to wait for a time that it will come. But when I saw this opportunity, I said, let me just chip it in. Is there something that could be done from the side of the board to see if more places could be accredited? Thank you, sir.
Thank you so much, Dr. Ewo Mazino Alexander. Thank you so much. Sir, we have just one person left with his hand up for questions. I'd just like to take that one person and then you react to the four of them at once. Thank you. Dr. Abdulwasiu Lawal, over to you. Let's make it snappy.
Thank you very much, Inyoloa. Good evening, my registrar. Good evening, everyone on the platform. I'm glad to be here. Actually, my question is also in line with what sorry, I didn't get the name, what my previous chief just mentioned with regards to accreditation. And I also wanted to comment on the way we young physiotherapists, especially those that are yet to enroll on internship, the way we perceive the thing. The problem is, first, I'll come with my commentary, then the question will also come in. I believe it's very frustrating when we finish graduating and then securing internship becomes a problem. But along the line, what I've come to understand with series of meetings and knowledge that get to me, including what Dr. Divine Favor mentioned when we had the meeting with the registrar as regards accreditation, and some of the experiences I had during accreditation, while I see the board came for accreditation and all that, I came to realize that the problem is not actually the board, but rather most of these institutions that were meant to train us. I believe the board has a standard, and the reason for this is to make sure that all graduate physiotherapists get the adequate knowledge that is needed for them to thrive after they've concluded their internship. But most of these hospitals, like the prof mentioned earlier, they have equipment, some outdated, some not even working, some as disguise. And then we think that these institutions, they produce interns with adequate knowledge, only to find out at the end of the day that they are doing more harm than good. I believe this is what the board is trying to regulate. And that is what they say. If you don't have enough equipment, try, get it, speak to the hospitals, let them secure this equipment so that we can have interns being trained. But unfortunately, the interns are directing their grievances towards the wrong direction to the board, that the board is not doing well, the board is not doing that. Meanwhile, they forgot that the hospitals don't have what is needed to train them. I know it's frustrating because, yes, you feel like it's just better, let me go for anything that will just train me, let me just have this permanent license and move on. But it affects us at a long run. Then I love the way that the board is now trying to include private clinics to see how they can also train graduate physiotherapists so that they can have their internship done there. Then, like what the doctor just mentioned now, I'll also join him in asking if there's anything that can be done. Perhaps the limits, or let me say, the minimum standard that could actually help private clinics to be able to train interns. It will not be easy for a private clinic to have pediatric unit, geriatrics, and all the other specialties that are present in physiotherapy. And I know it's going to be cumbersome one way, but is there any way in order to make sure that we have more institutions that can train physiotherapists, especially now that even traveling far distances have become a threat? You see somebody from Ilorin trying to go to Sokoto, or somebody from Enugu trying to go to Maiduguri for some internship exam or something like that. So this is my question that is added to what the doctor just said. Thank you for the opportunity.
All right, thank you so much, Dr. Lawal. Thank you so much. If we have a question from the YouTube stream link, I'll just go over it, just 2 questions relating to what every other person have asked. One, are interns supposed to be forced to pay association dues? For example, NSP dues, ACAPAN dues. 2, the person asked that in his facility, interns were also asked to pay 5,000 naira for CPD points compulsorily. Is this appropriate to be done? So these questions are posed to the registrar. You have the floor, sir, to help us address all the questions, comments so far. Over to you, Prof.
All right. Thank you very much. Thanks a lot. So as I've said, I'll be fast, but usually when you are fast in answering questions, you may miss out some points. So I don't want it to be seen as what I've just said will be the present situation of things. With more prompting, in this meeting or in another meeting, possibly the full picture may be seen. So number one, where are we with regards to the issue of centralized posting? Remember, I mentioned that Federal Executive Council is involved. And remember, I said Ministry of Budget and also Ministry of Finance are involved. So this is an interministerial matter. I'll give you an example. I can't remember what hospital, but a minister went to a hospital to commission something, and house officers demonstrated. And the minister addressed them, and he told them, he said, see, we developed the policy, but to release funds, and I think it was about their payments. They were supposed to be paid. And Minister said, this was on news, and that's why I'm saying it here, because he mentioned it and it was on news. And he said, we need to have this funds to be released, and we don't have power for release of so these are some of the things that are there with regards to these matters, because I've told you, if they present it at Federal Executive Council, the Ministry of Budget will be asked to work. And if you now go to the ministry, it's either they will tell you that there is still something that needs to be done at the Federal Executive Council, and they're not going to tell you what that is, because when they have their meetings in Federal Executive Council, there are some things that you see ministers come out and report to the public. There are other things that they want to keep to themselves until it's over, and then they announce it. So it's possible they will say it is at the budget office or Ministry of Budget or at the Ministry of Finance, and our hands are tied. We need to wait until they complete their own part, and then it comes to us before we now begin. So this is what the situation is. It's not necessarily at the ministry. It's possible it's either at the Federal Executive Council, Ministry of Budget, or Ministry of Finance. But I know that the minister has said he's going to on that to get to that point. And when we ask as registrars, you are not going to push to say, okay, what's happening at Federal Executive Council? The minister is not going to listen to that and tell you. So please, let's be patient. I know we can push, but as someone said, it is not just the responsibility of one party. I was very happy when you came. I took you to the ministry. Remember, I got a physiotherapist working in the ministry, linked you up and said, collect his number. He can be able to follow up on issues while we are following up from a level. You too can follow up from another level. And I think that will help us to move faster. The issue of bullying and no supervision. Someone has already mentioned, we have developed, there was never a guideline or policy or regulation on internship. I don't know one in the board. So people go for internship and you don't have something that you would measure them or those that are supervising them. So we developed one, and Tochinwe Obikwe, HOD UNTH, was the one that chaired the committee. They developed it. They have already submitted to us. It is on the agenda for stakeholders meeting. We have released circulars for meetings with dates, and I think that of internship is coming up in the next 2 weeks. So I will suggest that when you see the invitation, that you attend, so that you can look at the guideline for internship and be able to make input. And what we have there is, what are interns even supposed to learn during internship? I don't believe that it should be a repetition of what they did in the university. So internship is a transition. There are some key issues that we should look at, even though they will learn other things, but the assessment is going to be on some basic key issues. Then another thing in that guideline is what are the responsibilities of the supervisors? Then what are the responsibilities of the interns? Issues that have to do with the hospital itself, and then other things about the system. So if we have regulations, we can be able to now say, okay, when there is a problem, let's go back to the regulation and see what it says so that we act upon the problem that we have. And this is something that we are going to submit to the minister. Since there is no governing board, if the minister approves it, it is going to be gazetted. And the moment it is gazetted, it becomes federal government regulation. And you can be able to refer to it whenever you do anything. Another thing is, we don't have any fund. And I think there are two ways that we can be able to get that fund. If we are to put it in our budget, so now fund for what? For supervision. Because in the current guidelines that we have, Regulation 2006, there is this issue of sending board staff or resource persons to go to the institutions where internship is taking place and supervise. But then, when you are going for accreditation, the institution pay. When you are going for induction, the institution pay, and therefore you send people. So if you don't have payment for such activities, just like surveillance inspection, there is no one pays for inspection. You are not going to ask someone that you are going to inspect that you need to pay for me to come to do inspection, because the inspection is even supposed to be without notice. So these things are not being paid. And our budget is not a budget really that is now that we are trying to work towards expanding it so that it has all that. Our revenue also is not huge to be able to now accommodate all that. You will see pharmacy, you see many been going around with very big cars, and they go to this place, they close it, they go to this place, they close it. The cars that we have in the board are a few old, but we understand this important, and it's part of the current discourse. How can we strengthen regulation? So either going into the budget, or there will be a fee. Say, and that is a burden. That's something that I really don't want to see happen. But if it's really very important in the interim, before we have a budget that's wide enough to accommodate that, we say that when an intern registers on the portal, but that's not something I would really want to happen, as I've said. But the primary thing, we work on the budget so that we have some funds, and we say wherever you do internship, we send someone a surprise visit to see what's happening there. But apart from that, you can also report to the board what's happening. So these are some of the things. The issue of association, I'm a member of association, but I'm not an executive. I don't have that mandate to speak for the associations, and therefore I'm going to try as much as possible not to delve into that. Someone mentioned the issue of ASABA. The fact that there is no governing board has affected many things about inspections and surveillances and disciplinary actions, and it is not just MRTB, all the regulatory bodies. I remember when we went to one of the regulatory bodies to have interaction with them, they told us, they said when they get a case, they keep it, because if they made out disciplinary action, someone takes them to court, the court is going to ask, did you follow what the act says? And what the act says in all our regulatory bodies is that there must be an investigating panel and disciplinary committee who are members of the governing board, and there's no governing board. But what I did, I went to see the minister and I told him, I said, this thing is affecting board activities. Since the act says if there is no governing board, the minister takes over the function of the government. I recommend that you appoint those two committees. Since you are now governing board, you just look for people, appoint them, and court will accept that. And he said, oh, that's a good idea, but give me a little time. Let me find out if the governing board will be constituted soon. If yes, let's go with the governing board. If not, then we will now, he will appoint people to serve. So if with that, you can be able to have any report go to the investigating panel, and when they investigate, they now send it to you, you now forward it to disciplinary committee, and then disciplinary committee will take action. Now, the issue of needing more centers. With P&O, they complained. They said there is no single public facility that is doing internship, P&O. The same applies to speech therapists and audiologists. And therefore, when they complained, I said, well, we have this letter that we have sent to the institutions. We'll follow up from the minister that said they must establish. But I said, go around, find out any private institution that can do this. Find out why they will have challenge having the board come for accreditation for internship. And most of them said it was the issue of funds. Then find out how much they can be able to pay. So when they told us Some said they can't pay anything. Some said a very ridiculously low amount. I said, don't worry. I now worked with the professional. He said, where you live is not far from this institution. Do you agree to help these interns, potential interns? Go there, do it without honorarium. Maybe with just transport fare. Some will say, well, I wouldn't even collect anything. I know some people that did that. We waived the administrative charges. The resource persons waived their allowances, and we were able to accredit, I know for P&O about 5 or more, for speech therapy and audiology about 2, 3. And that's how we have been doing it. And I've told them, wherever you see any, let us know what are their challenges. In as much as they have the minimum benchmark for them to get accreditation, even if it is partial, let's accredit them, even if it is free. So the same thing with physiotherapists. Go around, discuss with senior colleagues that have private institutions, in as much as they have what it takes to do internship. Of course, you cannot be able to know for sure. We must go for accreditation to know that. But at least you can be able to look around and see what they have and then encourage them. If they can't pay, I assure you, waive. But I don't want to say this for people now that can be able to afford it to say, no, we are not going to give anything. So what you are going to do is to try to see their capacity. You'll be able to know. Nnamdi Eze cannot tell me that he cannot afford to pay for accreditation, even if it is a very reduced amount. So to assess them, then let us know. But what they can do is just to go to a general hospital or specialist hospital that is not doing an internship. Maybe they are not even accredited. Have an MOU with them. Let them agree that you'll be sending the interns there for some of the postings that you don't have in the clinic. The moment you get the MOU, when we come, we look at your clinic, we look at the hospital, we put everything together. If you have the minimum, we give you. And we can do as many as possible. But we need your support. We can't go around asking people to come and do an internship all across the country. So we need your support in that area. Another thing is that we have written letters to all universities. We didn't send, because around the time that we were going to send the letters, this NUC matter came up and there was chaos. We kept it. But now that they have realized they can't do without us, we are going to release the letters. Every hospital must send us the list of their teaching hospitals, because we have realized some hospitals have been used that are not accredited. And some hospitals, you'll have one hospital, 5 or 6 universities are using it as a teaching hospital. And therefore, we are going to regulate that. If your teaching hospital is overcrowded, you have to look for another one. And wherever you are going to, it must be accredited. If not, by the time you graduate your students, no induction for you. So if we do that, more hospitals will be accredited. And if you are accredited for teaching, say that, why can't I do internship? And that will help possibly to have more places that can do this. Now, the question that my Oga asked earlier, the issue of how do we adjust the accreditation guideline? We are not going to go below the minimum. But what we have done in this new guideline is that instead of saying you have not met the requirement for partial or full accreditation, and therefore just denied, what we want to do is to have levels. So you can be accredited, either partial or full, but you will be at level 1, another hospital will be at level 2, another hospital will be at level 3, another hospital will be at level 4. And we have criteria for each level. So what that means is that you can be a hospital that you think is a giant hospital in the country being respected, but you see that another hospital is above you in level. And on our platform, which we have already completed, we now have an accreditation portal. We are not going to do manual things anymore. On that portal, there's a public search, just like we have public search for the registration portal that we have. Anyone outside can go to the portal and check your status. So people can go and check the status of the hospitals. So that way, people will know at what level your hospital is. So that's what we can do, to say that, okay, this is the minimum, we can't go below it, but you can still get accreditation, but you'll be placed at a level, and it's up to you to accept what level you have given. Interns supposed to, well, that's the one of those that I said I'm not going to, because if you join an association freely, and the constitution of the association says that this has been prescribed, or the constitution says that AGM can prescribe something and you are mandated to do that, it's your free will to join. And in as much as you have joined, whatever is bound on you need to do that. No law will come and say you shouldn't do that. Now, the same thing with paying 5,000 for CPD in hospitals. Hospitals have their own structure, they have their own management, they have their own ways of doing things. And therefore, if you join and management has fixed something that is part of the, it's just like a university. You go to a university, they say these are the things that is binding on you. You must pay A, B, C, D. And if you agree to get admission and also to start the university program, you will have to follow that. So the same thing with the hospitals. If this is their policy in the hospital, then it's up to you to say that, okay, this is not the place where I want to do my internship. Let me not do it there because I'm not going to pay this. I wouldn't want to be forced to pay this. But anything that is not within the law and it's done, then you can challenge that. And if sorry, calls keep coming in and I have to be rejecting them. But let me just summarize and stop here. So it's based on principle, whether association or the hospital, do they have guidelines? If there are guidelines or rules or regulations about doing things, but if there are none, then you can be able to report and then we'll see what we can do to help. Thank you very much.
Thank you so much, Prof. We really appreciate your answers to all the questions and concerns that have been raised so far. Before we move to the next agenda, based on one of the answers you gave, sir, I just want to ask, does that same answer applies to certain complaints that have been sent to the board concerning queries about either a particular person is a quack or not? We've seen on Emerald TV groups where people send pictures or flyers, posters of a certain person in a certain state and trying to confirm if this person is actually a physiotherapist or not based on the practices or the treatment sessions we've seen on their social media pages and all. And people always wait for a response or something from Emerald TV board to that particular post to just react and let us know what is going to be done to such type of persons. But over the years, couple of months, we've realized that it's always been a silent response from the board. So the answer you gave concerning no governing board, this and that the Minister of Health is yet to approve one or two to another, is that also the same answer to as why there has been no step being made by the board to tackle each of those cases that we've been seeing and have been sent to the board, sir? I would like you to answer that, sir, before we move to the next agenda.
Sure. So two things. Number one, the issue of posting on social media. See, the social media, it's a place where we socialize. And that's why it's called social media. We socialize. Release information. Sometimes we do jokes, sometimes we fight, sometimes we discuss important matters, we understand them. But as I've said, if you have a regulation, in place of work, there was a place of work that something was posted on social media, on the WhatsApp group. I've worked in many places, so I don't want to mention which of the places. And said they are going to penalize someone for not doing something because it was posted. And there was a discussion. Said, no, we have never sat down in this department and agreed that if posting is done on this social media, that it is binding on everyone. They said what the institution agrees is official email. In departments, usually you will have these racks where you put information for people. If someone is sent those information and they don't comply. So what I'm trying to say is that there's a lot of discussion because it's not part of the regulation or guidelines or policies of the board that there is someone stationed on those platforms to be able to collate and then formally implement. When we see them, I mean, sometimes for myself, sincerely, some of the platforms right now, if you look at my phone, you'll see 1,000 messages. You'll see 500 messages. It's only when there are important discourse that I think it's important for me to understand what people are coming up with that sometimes I follow part of it, or if I can. So, and the same thing with my staff. I can mandate them that you must be on social media at your own private time to be able to collect what people are saying, bring them to board, and then we begin to implement. I think people need to understand that there are formal ways of doing things. If we sit and agree that those platforms are formal means of submitting complaints to the board, then that's a different thing. But right now, that is not the case. We have a surveillance program. In every state, there are surveillance volunteers. We give them manual, we give them jackets, and we give them other things that they need to work. And there are emails, at least surveillance@mrtv.gov.ng was released. There is also at mrtv.gov.ng. These are emails that people can use. Of course, I must admit that we have not maybe sensitized physiotherapists enough. I admit that. We're not perfect, but with this kind of meetings, we'll take note of things and do things better. There are things that we have done recently that we were not doing is because of the feedback that we have gotten, and we're improving. So I assure you, we improve. Now, the issue of not having investigating panel or disciplinary committee, does it stop us from doing things? No, it has not stopped us from doing things, because we have a preliminary investigation team. So that, and we have inspectors. So we have surveillance volunteers. If you send something to us, the first thing we do is to ask our inspectors to go and verify. So if they verify, we now ask our preliminary investigating panel to now discuss with those involved just to see if there is merit in the case that warrants for it to go to the investigating panel. It is when we get to that point that we can move forward. Recently, we had a case reported to us. We followed these stages that I told you, but the person was not happy, went to court, took us to court. For 3 months, we were going to court. And at the end of the day, we won the case. So the case was not a hearing that the person should be punished, but it is just a hearing. What we did in the board, was it legal or not? And at the end, we won the case. There are other 2 cases. When we got to that point that the preliminary investigating team has done its job, and we thought if we made punishment on this person, if he goes to court, we have not followed the steps. What we did was to now hand over to the commissioner in the state. And the commissioner, because they have their law within the state, they took the case to court. And that's how we took care of the case. And so there are ways that we can be able to still do things, but that issue of not having governing board is affecting us. But we have complained, and the minister has assured us very soon he's going to take action, and we are going to sort out that. Thank you.
Thanks so much, Prof. Just to clarify your response very well, because we also have a lot of students, NAF students currently on this call who want to know how things are being done at all. So if we would like you to help us to, maybe any of your board members currently on the call, to help us send those emails, the proper means of contacts, reports, and all that we have to send to the appropriate channels that all these complaints can be reported to in time. That's one. Then 2, sir, are you saying now that if we have any reports to make concerning each of these cases and we go through the appropriate channels, which will be provided by any member of your board to the general public right on this call, are you saying that necessary steps will be taken against those set of persons? Is that what you are saying? Or are you saying that even if you get those reports and those cases, we still have to wait for the minister to set his own action into place for the whole governing board of 18? Is that what you are saying, sir?
Okay, well, number one, about the issue of sending out the emails, we'll send them out. But I just also want to let you know that we have upgraded the website of the MRTV. I would have shown you, but the technical person said we should wait until they are done before we launch it, and that will be possibly next month. We'll launch it. So in the website, all these links will be there. And remember, I said we have developed portal for accreditation. It's not just accreditation. Every single activity of the board is digitalized now. We have a portal for surveillance. So if you go to our website, you'll see link to report surveillance, and you just click, and it's going to give you just like a website that says contact us, that gives you a space to put in your name, the information or subject, and then a box where you put in the details. We have something like that. We also have, and this open to physios and the public, general public. If there's a misconduct, they can go there and upload. So we are going to have that. Everything, as I've said, has been digitalized. In July or August, we are going to launch it, the website and all the portals. There's going to be also an app that you can have on your phone, so that when you enter the app, the link to all the portals will be available. I think you were asking the issue of whether we have to wait for the minister before things happen. I think I've answered that, right? That we have some things that we do, but when we get to that point that investigating panel or disciplinary committee has to act, what we do is to look for another regulation or the state or any other way that we can be able to dispose of the case. Very soon, the minister will approve those, and then we'll be able to be routing them through the proper channel. I have a feeling that I missed that question, but if I've answered it, fine. If not, just let me.
Okay, thank you so much, Prof. Before we move to the next agenda, we would also like a member of your board to help us with, you mentioned something that there are surveillance officers in each state. So if you can have like a contact person of the surveillance team for each state, so that we don't have to keep bombarding the website only, and we can also have multiple ways to reach out to the board for cases like that if we have to make report. So we can go through the surveillance officer directly, or we can go through the website. And I'd also like to have contact of either their contact or their mail or any way to reach the surveillance officers that pertains to each state. Just a suggestion from my end.
That's noted. We'll do that. We'll do that. Okay. Thank you.
Thank you so much, sir. I would like to go to the next agenda for the 9th. So in the last couple of weeks, we've been seeing quite a number of uproars on each physiotherapy group, NSP group, MRTB group. We've been seeing discussions going on concerning a certain case whereby issues of community rehabilitation workers, community health workers, CHIL, CREO, diploma in physiotherapy, PPP project, and all. We have this is a forum for early career physiotherapists, and we know that not everybody have been opportune to attend the 2 meetings that has been called by the board to address some of these things. So we would like to get a good explanation as to what is going on, sir. This particular case of a diploma, CHIL, rehabilitation 2030, and all, so many early career physios do not understand what is it about, and we want to know the stance of the board as regards it. We want to know what's the way forward. Also, on the PPP project, we would like you to explain very well to the general early career physios. You have the floor, sir.
Okay, thank you very much. Let me start by apologizing to all of you, especially those that saw my posting as being maybe unnice or at least not being autocratic. Someone, I think, posted that word, just picking the words that people have used. Let me apologize if it comes out that way. Because sincerely, for people that know me as a person, I don't want to say things about myself, but then people that know me would that I wouldn't really come out and just put things on people and say no one should have a say. But we are human beings. I'm a human being. I know I can make mistakes. And sincerely, whenever I do think that I need to adjust my attitude or my approach, I listen, I try to do that. And this is that time that I'm going to say, if any of my postings or any of the things that I've done has come out that maybe disrespected people in a way or make people to feel that they don't have a say in things, I'm sorry about that. I'm also happy that you mentioned that meetings have been held because that's important to acknowledge, and I'm happy that you have acknowledged that. So as this matter is a matter that I can take a very long time explaining, because I was telling someone, I said, look, the board and myself as registrar didn't just wake up one day and just say, let's do this, or let's take this part. It took a long time of understanding policies and data and information and statistics and all that. And also interaction with people. People say, well, this one will say this, another person will say another thing. And then you have to just put everything together. And that is what we do as leaders, as managers, and that we have a lot of information, we must synthesize, and then at some point we pick and select what we are going to do. So with that background said, very briefly, as I've said, I will try very briefly, but if information is missing, it doesn't mean what I say in just this short period that I've been given to explain this, that is the full position, complete picture, what it is. So I just want to make that a statement before I respond to the issue of diploma or middle level manpower. So let's start with number one, what all of us have agreed. And in the discussion I've followed, I've not seen one single person that says that people, Nigerian citizens, should not get the services that they require. I think this is something that we have all agreed, that all Nigerian citizens should get the services they require. When you talk about universal health coverage, I don't think there's any single person that denies the fact that universal health coverage is important and that every country should move towards attaining universal health coverage. It doesn't matter how many years it takes, but at least all your plans should make sure that you have the maximum that you can be able to produce so that all those that are in everywhere they live in the country, because that's what universal health coverage is all about. It's about three things. Number one, who is covered. So meaning it doesn't matter whether you are in the urban area or in the rural area. It doesn't matter whether you are poor or you are rich. Should be covered. Every single person, vulnerable, should be covered. What should be covered? So all the area of rehabilitation professions. Now we are talking of rehabilitation. All the area of rehabilitation professions should be covered. Physiotherapy should be covered. Occupational therapy, speech therapy, audiology, and what have you. Every. So then number three is financing. It must be financed, and that is why there is issue of health insurance and there is issue of budget lines for things. So I think we have agreed that everyone should be covered. Then number two, do we have the capacity at the moment to cover the whole country? Of course, we don't have the capacity to cover the whole country, but what is it that we can do to be able to cover the whole country? So that's number three. So, but number one, is that capacity there? In the next 20 years, for example, or 10 years, will one cadre be able to cover those needs? So these are the issues now. And we all know, and I think we can agree, and I think from all the discussions we have had, no one has denied the fact that people with degrees, physiotherapists that have degrees, DPT, bachelor, will not be able to cover those needs. I've given the statistics. We have registered less than 8,000 for 60 years, because from the 1940s until now, everyone that has been registered in MRTB is not more than 1,000. And the WHO has shown that the normal, what is required as ratio is 1:2,000. But if you look at it now, we have around 1:200,000. So these are some of the statistics. And people think you can be able to produce more by increasing the number of universities, and in the next few years, you can accommodate the number that will go and serve all Nigerians. As I've told you, I'm in Ukigwe right now. Tomorrow morning, I'll proceed to Uchu of Grigori University. Last year, I was there. They graduated 2 students. This year, tomorrow, I'm going to induct 7 students. In Lead University, if there's anyone in Ibadan, just reach out. We had professional exam just last week or 2 weeks ago. There were only 2 students in Lead University as final year students. Of course, many have 150, but if you look at the 150, they will have 4 or 5 full-time staff, and then maybe 3 or 4 or 5 part-time staff. And we told them, the equipment, you go, they don't have equipment enough to be able to even train 50. And therefore, we started indexing. We said, if you don't have the staff, train only 50. But if you can double or triple the staff, then that's when we can increase your quota. So if they don't have the capacity to train more, then they are going to reduce the number. And therefore, our thought of producing more to cover what we need to cover also is decreasing. And the more you produce professionals, the more they leave the country, the more they want to stay in urban areas. And the more you produce, the more the population increase, the more hospitals in urban areas, teaching hospitals, general hospitals, specialist hospitals, all will be coming up. And so there's a lot of statistics. In fact, I wanted to give an example with the issue of other professions, that you have 90,000 currently in the country, but you don't see them in rural areas. You can see them as supervisors in local government, going around to see what other lower cadre are doing in the rural areas, but they don't go to the rural areas and stay and work. So those in the rural areas, all this is about them, about humanity as health professionals. Number one, we want to solve societal problems. Number two, we are thinking of our pockets and our families and all that. So I think there should be that humanity into it. There should be that issue of solving societal problems, and look at your own responsibility, that what you do is to take care of yourself. But the government is looking at, even if it's seen not to be a very responsible government, is the opinion of people can see it as responsible, but then it still has a responsibility to be able to make sure that they solve societal problems. So I think we also have not seen any debate that physiotherapists at degree level can cover all the needs. I've given statistics about the number of primary healthcare centers registered, 34. And if you look at the catchment area, one person cannot be able to cover. Even if you have two, you have 64,000. And there are people that are in the communities, they don't even know the primary healthcare centers exist. Someone needs to go into health posts. And those health posts, I don't even know how many thousands are there in the country. So the need is there. This second part also, we don't have any disagreement, I believe, that there is need, and also that as professionals, we can cover the need. Then what is the alternative to adding to the workforce, especially those that will go into the hinterlands, to be able to help people out there that are not educated, they don't even know hospitals exist, they can't be able to come out and access the services. So this is where we differ. And two things there. Number one, the issue of fear of each of the alternatives that are proposed. And the fear is a very genuine fear. Everyone has that fear, including myself, because I was president of NSP. We had that fear. But because the responsibility, just like ASU was going on strike because government has not provided funding to universities, members of ASU said, what's your problem? Is it your responsibility? In your constitution, what your responsibility is to welfare of your staff, of your members. Focus on that. Forget what government is doing. You can advise them. You can't go on strike because of that. And that's what we did. We're doing DPT, we're doing the college, we're doing this, we're doing that, interest of users. But you also have to consider that government also has its own responsibility to ensure that all citizens get the services. So we all have this fear, and it's a very genuine fear, because we see it with our own eyes, that you produce the middle level manpower and a hospital will take 5 in place of 1. We see that. We see quackery. This quackery is all over. You treat a patient today, when he knows how to use infrared, he can buy infrared and go to the village. And we don't have very strong regulatory mechanism that will checkmate those things. Just like people keep saying that in the diaspora, US, UK, they have that strong this, and therefore they have PTAs, they have assistants, they have this, they have that, and therefore it's fine if it is there. But here, it's not fine because the regulation is not as strong. So there are many things that we can list. These are problems, and agreed, they are problems. But the question is, when you weigh the problems and the need to treat those people that are not getting the services out in the rural areas, do you just say that they shouldn't get the services, wait until we solve the problem, or do you address both? You begin to see how you can provide for them, but at the same time, you target the problem, no matter how big. If everyone put in an effort, we'll move from where we are and continue to reduce the impact of the problem. So this is just a background to that third level. Now, how did we come to have discussions on what services should go into the community? 2023, I came in as registrar in August, 1st August. And in November, we called for a stakeholders meeting on Rehabilitation 2030 initiative. All the associations were there. The presidents, in fact, themselves were there. Government was there. NGOs were there. Professionals were there. We met virtually and physically. We discussed all the components of the initiative. One of the very strongest components is the issue of integrating rehabilitation into primary healthcare and community. And at the end, we had a resolution. And the resolution emphasized very strongly, unanimously, that there must be rehabilitation at primary and community levels. We all agreed. But how do we go about that? There wasn't any suggestion that was resolved. It was after that, one day I was sitting and I got a call. I'm not going to mention names because I don't want to mention names when people are not in the meeting where I'm mentioning them. So someone called me and said, I did my PhD in a country where they have a solution to this problem that we have created, that there must be services in the community or at the primary healthcare level. I said, what is it? I said, community rehabilitation worker program. I said, well, not aware of the program. I will study it online, but the best thing, why don't you lead a team to come up with a proposal on how to establish it? The person said, I'm a very busy person. I can't do that, but I can be a member. Set up a committee with another chair. That person was a member. They developed draft of a curriculum. But the curriculum had some elements of physiotherapy, say physiotherapy, explain what physiotherapy is and things like that. Then another person came and said, I've heard this is happening, but I want to advise you. Make sure there is nothing in there that says physiotherapy or occupational therapy or what have you. What you need to have there is just that how do they assess people and know that they have disability or need for rehabilitation. Then let them understand the referral system. Then let them also understand health education. Let them be able to explain to people that this, your condition is not juju, it is a medical condition. If you go to a hospital, primary healthcare center, you can be able to get, so those kind of things, he suggested. So they say, okay, come, be part of the team. They now develop something. So at that point, things went out. Chaos broke out. I called for a stockholders meeting and people came. Some people said that was an idea that can be considered. Some people, very few. Most people thought of CHU, that community health extension workers, and some people said just generalists should just be trained in the hinterlands. Generalists, maybe just secondary school leaver, just train him, this is how to identify this. And so many people said a number of things. I said, okay, out of all those that spoke, I picked people and I recommended to the House, let's have these people to form a team, a committee, to refine all these things that you have discussed, get more information and present it to us. What do they want? And we asked them to meet. They went, they met, they came up with their proposal, submitted. That was when we had one of the issues they raised, say, don't do community rehabilitation as a diploma. Train CHUs to be able to do this thing. And some others that they mentioned. But the others were things that there is no institution that can do that. For example, if you say secondary school students should be trained, those that finish secondary should be trained to offer rehabilitation, who is going to do that? We don't know an institution that does that. So if you now say that is the way to go, you don't know who to approach and say, okay, do it. Both does not have the mandate to go into the hinterlands to begin to train secondary school leavers to offer rehabilitation. And therefore, the two that we saw, that we have agencies that we can approach to be able to do that, where the issue of CHUs, training CHUs, and also the issue of community rehabilitation. So after that, I called for a meeting in the board because Community Health Registration, Professionals Registration Board is the one responsible for CHUs. And then MBTE, because CHUs have also been upgraded from just ordinary diploma to a national diploma. And therefore, MBTE is the one that approves their curriculum before they do it. So we called MBTE, we called Community Board, and this committee was invited to present to them. And the committee presented first the scope of rehabilitation, saying there is ICF, there's impairment, there's disability, there's handicap. You must identify problems at all those levels. Then you have physical rehabilitation, physiotherapists, occupational therapists, you have sensory problems, speech therapists, audiologists, what have you. And then you also have mental rehabilitation, and you have social rehabilitation. So the context was wide. The moment they listened to it, someone from MBT just said, well, we have the curriculum. And we know that I don't know if someone, Yusuf Shuaibu, is trying to ask a question. I can hear some, maybe if you can mute. The person said, look, we have the curriculum. And the CHU curriculum is so full of information because every professional that wants to get into the community level goes into CHU. Therefore, formally, it will be very difficult for the context you presented to go into that curriculum. Then another person also mentioned something about fear of handing it over to other professions. I remember there, while the community was there, the person said, are you going to take this rehabilitation and hand it over to community? If the people that have been trained begin to misbehave, can you control that? Because even if you take them to court, court will say who is their regulator. Community board is their regulator. Then why are you interfering? Allow community to regulate that. So that person raised this. The registrar of the board was there. And they also, he and his team countered. And at the end, I said, please, let's leave this. What's important, let's have this in the communities. Who regulate is not the problem. Later, when we get to the bridge, we'll cross it. And therefore, I suggested, let's form a committee between MRTB and the community board and the MBTE. Let them go and look at the curriculum. We didn't even say we are not going to consider putting it in the choose curriculum. I said, let's go and look at the curriculum. What they are saying that it is overloaded. Let's even see whether there is some space that we can put what we want to put in there. We agreed. Immediately after the meeting, I wrote to the registrar of the community board and said, give us 3 people, board will give 3 people, MBT will give 1 person, and then let's discuss. For 6 months, I kept reaching out to the registrar, never got any response. There was a day we agreed that I will meet him in the board. I went there, and when I called him, the phone was not going. I used WhatsApp, and he answered, and he said he wasn't even in the country. 6 months. Then someone, I told him, I said, what's happening? He started working with this board. But now, it's appeared. The person had worked in the community. And he said, the fear you have is the fear that if you come into their profession, they think you are going to monopolize their profession and interfere with it. Possibly that's why they are running away. I don't know. This is just what someone whispered. But at the end, what I did was to say, okay, let's call for another stakeholders meeting. And that was the second one that we called. And in that stakeholders meeting, we presented all the updates that had happened. And at the end of the day, we said, from what people or organizations or government agencies can implement, we have 2 positions. Train CHUs or train community rehabilitation workers. I said, but we can't have way to get to community because up till now, they have not given us the chance to sit with them and see how we can impute things into the community at CHU. And therefore, what we have now that is feasible is the community rehabilitation. So after that, the meeting, what we did not agree at that meeting was the issue of who regulate. But no one objected to having community. But someone suggested, he said, in the interim before the community comes up, if that's the one that will be chosen, let those that have already graduated at CHUs be trained, even if it is no full complement of what they need to know about rehabilitation, that at least they can begin to offer those services before the other one comes on board. So when we left, I wrote to the minister. I said, stakeholders meeting, this is what we have been discussed, this is what we have as options, and therefore I recommend let him be the one to call community and MRTB to come and sit on the table and discuss if we are going into the community. But then we also reached out to MBT and they said they already have a curriculum on psychosocial rehabilitation. They thought it was full. Now that you are coming with physical and mental, it's going to be overstretched also itself, but it can be reviewed. And therefore we had a team that reviewed it to have a draft so that at the end, we have 2 options. And that is where we were at when this issue broke. The plan was to now present this update to another stakeholders meeting. And I think I've mentioned it, that we are going to call for that meeting. We are going to call about 6 stakeholders meetings, 1 virtual, about 3 or 4 physical, with only physiotherapists. And when we finish all that, then we'll now inform the minister that we have had all these stakeholders meetings. These are the resolutions. And in those meetings, I'm only going to give an opening remark. We are going to have people that will sit on the table and chair, so that if people think it's my interest, let me not even be there, so that I will not be seen to be biased. Whatever is collated, we'll then take it to that meeting where we'll ask the minister to send a representative from the ministry. We'll ask all these other stakeholders. We'll also have disability groups and associations also to be there. Then let's discuss it generally. Tell the ministry our concerns, that we don't want this, or we want this, or we want these things to be done this way. The minister's representative can take that back to the minister, and then the minister is going to take judgment on whatever he says that they wish to do. So at this point, I'm going to tell you, from what I've told you, and you can go and verify. The only thing is that I've not given you names. I don't have any interest on who offers rehabilitation at the community level. I don't have. There is none of the action that I've taken that was my own action. These were recommendations from individuals, from committees, from stakeholders meetings. I was only implementing them. What I've said, and I still stand by that, is that I believe very strongly that people in the rural areas should get the services that they need. And that service is going to them. It's even going to help those that are in the communities. I once went to a clinic in Kurna in Kano. I don't know if people know Kurna in Kano. It's close to the outskirts or local governments that are outside of the main city. I saw many patients lined up. One doctor was going to see them. And if you look at them, they look like they came from a remote area. So I was asking, I went to the hospital to see the doctor. And he said briefly he will see me before you continue seeing that. I said, what's happening? What's happening in your clinic? He said, CHOOOSE are the ones sending them into the cities. Say we can't even go to primary healthcare center because this your case needs a doctor that will be in the city, and they will send all of them. And that's one of the reasons why you will see awareness back there. So someone goes to say, I need your vote. They say, look, we have these problems and we need this in our communities. The awareness goes around. So this is the situation. There is the issue of physiotherapy technician. The person that advised we do community rehabilitation said that is the fear. If you use physiotherapy technicians in the communities, they are going to go with their infrared and begin to treat patients. Don't do that. But physiotherapy technician is in our act and regulations. Sorry, in the regulation. In the act, it said diploma. In the regulation, it specified directly physiotherapy technician. And this is a gazetted Federal Republic regulation. And at some point, ministry called me, said the policy of this government. I've had former registrars saying I was able to stop this thing. I told the universities not to, institutions not to do it. We are not going. So at that time, the government did not have a policy that you must produce. I just saw a post from nursing. They are sending them to the community, and it is ministry's policy. If you look at nursing, they have doubled the production of both degree and diploma programs. One day, the minister was boasting that they have almost tripled the number of nurses, both at degree and diploma level, because of the policy government gave. They gave us those directives at the same time. They followed. But for me, I told the minister, I said, sir, there's a difference between all those professions and ours. We have a problem that hospitals will begin to take those lower cadres. We have a problem that people are not employed. They are out there. I kept mentioning. It was in that meeting that he said, write to all the institutions, let them start the program. We mandate them to start. It was in that meeting that he said, write to all, that no institution should take beyond this number as a ratio. Write to all institutions. They should not take anyone to head. He kept mentioning those things. But I understand, even with that, his confidence to change things, there is a possibility by the time he leaves, that may not continue. I have that fear also. But when I look at the professional side, and I do a lot to see help. This issue that you raise about the what is it called? PPP is one of the reasons that the idea came. I will say, let's look at it. And I will talk about it briefly. But on the other side, The communities also need to have the services. So you can see where the dilemma is. So for the issue of the physiotherapy technician, go around, let in this meeting, anyone that has seen any institution that MRTB has approved for them to do a diploma, please list them on this platform. Only one approached the board. And that one, when we gave them the guideline, and we said, if you are going to train them to be able to use short-wave infrared, so this and that, you need to go. Up till today, they have not. They said they are going to come back. Very soon, I know they will come back and will go. If you don't see those things, because it's a stringent requirement, they themselves will run away. Because we want a situation in which we breach some gap before this. If government wants it to come, they will come. I told them. When the minister said double quota, not seen MDCN, they doubled. But have you seen us double? What we did was to tell hospitals that you can double if you can increase your staff and your equipment. And they couldn't. And we are still giving them 50. Those that are institutions can be out as witness. We go there, we give them 50 instead of 100. We write to them, we say you must increase. And I told them, Minister, he will be speaking, I'll be shaking my head. And you say, okay, what do you want? At the end of the day, I got very close to Dr. Tunji Alausa, that at some point we named our board building his name because of the things that he has done to us. Because when he speaks, I said, no, this is what I think. This is what will help my profession. When he said do diploma, I said, I'm going to fight with my people. He said, Dr. Ayula, go and write a letter and give him, I say it's a mandate, so that if there's a letter, let me see what will happen. So all these things are there about the fear. One thing that we can do, as I've said, let's sit down. If we don't want diploma, I can go to minister and say, remove it from our act. But you, as the professionals, and you have a voice, association, whatever it is that you can put together, do a communication, tell the ministry this is the effect, we don't want it. If you can convince government to drop it, if it's not there in the act or the regulation, then we are all going to live in peace. But in as much as it's there, and government is there and said, do it. I told Dr. Akale, I don't want to mention names, but because she has made a post on the group saying this is what I did, this is what I did. I said, if a minister called you and asked you to do this, why didn't you stop diploma in the military? I asked her that in the OGM, and she couldn't answer. I said, if diploma is not good, what's good for the goose is good for the gander. The military people will retire and they will still go and be treating patients. Why approve it? Because military, you can't joke with military. You can't stop them. And then she said, no, in my last year, I stopped it and I gave directives. The last year, and I said, oh, why did you wait for 8 years until you were leaving? You now leave the burden on the person coming in to be fighting military. So this is the principle. If you can muzzle institutes that are not military, you can't muzzle the military. So, but based on principle, if it's in the law, you can't stop anyone. The only thing is that you can't encourage it. And that's my stand. I'm not going to encourage it. I've never asked anyone to do it. I will never ask anyone to do it now that we are trying to build capacity. If you grow, I've never had a neurosurgeon or cardiothoracic surgeon been afraid of a diploma because they have grown to that level that they can't, no one can compete with them. But I can see anesthetists or nurses doing CS or removing appendix, and that's where they keep fighting with general doctors. So if we have our postgraduate programs elevated to the level that it distinguishes us, at that time, we'll even be fighting. Another thing, changing the name. I've seen many posts, and I've asked MBT, and they said it's very easy. Whatever name you want to give us to use, the only thing is that there is cost, because you have to call for stakeholders meeting and pay. And I wouldn't mind. Let MRTB pay. Let the professionals come. Tell MBT what name you want them to call it. And I'm saying this not that I'm encouraging the diploma, because if it's in the act, until you remove it from the act, do something to subtle it down. Because an act takes ages to review. It has to go through National Assembly. We know what it goes through. First reading, second reading, public hearing, third reading, and then it goes to the Federal Executive Council. And we are not even talking of it has been submitted, because ministry has to take it to Federal. Minister of Justice is the one that submits. I know maybe you are giving me a hint that I should summarize. I will do that. But you have asked for my position, and there are many things, and I will try to summarize.
Continue, sir.
No, let me summarize. Let me just summarize. As I've said, if there's any point you want me to further clarify, I will do that. But in summary about this, number one, the need in the society, in the communities is there. In the past, rural areas had more population than urban, but now it's tilting. But there are still people there, almost half of Nigerians. 1 in 3 people need rehabilitation. 1 of 3 of 100 million is going to be over 30 million people that would require rehabilitation in the rural areas. We need to support them to get those services. Number 2, we know degree in physiotherapy is not going to cover all the needs of the urban areas and the rural. That I know we are not arguing. Number 3, what programs or what pathway should we select? And how do we ensure that it does not affect the prestige we keep talking about and the money that goes into our pocket? So it's just like a son telling his mother, don't give birth to another child because he's going to come and block what I will be getting from the house. The mother will never agree. So, but what you can do is just to say that, well, give birth to him, how are you going to take care of my education and his own education? So this should be the discussion. We wouldn't rush, but at the same time, we are not going to wait for another 60 years being afraid, because for 60 years we have been afraid. We are not helping these communities, and we also are not growing to the level that we want to go. So I think all these things, we need to put them into perspective. We can't do it alone as a board. We need everyone's hand, but we don't need hands that will fight with us. We need hands that will support us, that will help us. The way I listen to people, and I did all that they said without bringing in any single thing about my own view or perception or position. I assure you, whatever you bring, the only thing is that it's not board that will implement some of those things. So whatever you bring, it must be superior to the ones existing, so that government and the government agencies working on it will accept it and change the ones that are on ground being planned to the one that you are going to. And it has to be formal, and it has to be submitted to the appropriate. Now, very quickly about the issue of PPP. The issue of PPP came from an idea. This is something that, partly came from my idea, but partly, I was at NSP conference and there were presentations. In fact, I remember Dr. person that gave the remarks, keynote speech at the conference in Uyo. We had the discussion. I got ideas from him. Dr. Nnamdi Eze, I got ideas from him, put them all together, and that's how we came up with the idea. When I was in FMC Unguru, doing my NYSC in 2002, I was the only person, and I think I was the first physiotherapist sent there. There was a board member. As I've said, I don't want to mention names. He was trying to establish a department. They refused because they didn't even know the importance of the program. And when I went, there was no room. There was no department, nothing. I was going to the ward, see patients. They will pay the hospital, and I would pay my little allowance. I will go home. At some point, when the doctor started discharging patients, they now told management that these people, we are happy a physiotherapist is seeing them. In the past, patients are discharged, taken on wheelchair or something, carried, and they will take them home. But now they can limp themselves to live. It's important that you have an outpatient. They gave me a room, very small room, with just a desk and a table. I remember Malam Musa was working in Accord. I said I don't want to mention names, but this is a positive thing, negative thing. I went to him in Kano and I bought tents and infrared from him, went back. I was seeing the patients. And after some time, they now realized the importance of the profession and they established a department. I think someone from FMC Unguru is here. I can tell you that that department now is one of the biggest in the country. Because one of our colleagues through the National Assembly helped the hospital to build a very big department. Dr. Nnamdi Eze is here. If what I'm saying is not correct, he can correct it. He told me about his journey, how he went to a hospital, say, give me a room, let me have my equipment, see the patients, so that at the end of the day, what we have, we share. The advantage of you as a professional being there is that You don't need to pay rent. The hospital will provide. You don't need to be searching for patients because from the GOPD ward, they will refer patients to you. You just see them. And the money you get, you share. Where the problem is with PPP that I've heard from people are two issues. Number one, if it is a company that comes and establish PPP in a hospital, they can like themselves too much and they will shortchange you, the professional, and the hospital. Another thing is the hospital possibly being greedy to say that this is the percentage that they are going to take. But these are all things that if it's something that we think is good, can be able to negotiate and the MOU have something that will be favorable to the young ones. The PPP didn't propose at the ministry. And we have had meeting with the minister. We have had meeting with ICRC, is something Concession Regulatory Commission. They are the ones that allow PPP, and the PPP division in the ministry. The ICRC themselves said it. From what you explained to us, they said this is more like a philanthropic thing. And everyone laughed. Say you just want to help the young ones. They say, okay, we have a package that can be able to help in that kind of approach. And it is because we agreed that was possible. On Tuesday, from Uturu, I'm going to Inewi for induction. From Inewi, I will go to Ebonyi, Dufut, to meet with the CMDs, discuss with them. Let's hear from them so that we'll be able to know if it is something that can favor our young ones. Because this is about the young ones. We are not going to promote any company to go into a hospital. We're going to say, you, if you have few equipment, just come. You have an MOU with the hospital. They give you the space, they give you the patient, treat the patient, share. But I can't know everything. I had the intention after meeting the CMDs to call for a stakeholders meeting, because if you call for a stakeholders meeting, you won't report much. But I met with the minister, with the ICRC, with the PPP division, with the CMDs. That doesn't mean that we must do something. But at least I will have information. If I call for a stakeholders meeting, I can be able to say, okay, these are the issues. If you ask me questions, I can answer you and say, this is what this said, this is what that said. And then at the end of the day, if we agree, we'll then move forward. And I also reached out to a foundation that had volunteered to give 3 million. It's not a big foundation, but if that foundation, that's a small foundation, will give 3 million. If you continue to reach out to others, we can get more funds. We can say that 30 people get a proposal, get 100,000, buy your tents, buy stethoscope, buy this, buy that, just few things, go there, begin while you are doing it, what you are getting, you'll be expanding. After 5 years or so, you leave them. You go and get your own rent or build, and you establish your own, just like Dr. Nnamdi Eze did. And then they can now replace you with employing others because they now see the importance of it. So this is the idea. But of course, I've already mentioned it on social media, crisis has erupted. But the reason why I've not called a stakeholders meeting is because I want to get information from the agencies that are involved, and then I will present it. I'm sorry I took too much of your time. I still have a lot to say. I don't think we have the time, and I'm going to stop here. But thank you so much for listening to me.
Thank you so much, Prof. Thank you so much. I can see quite a number of hands being raised at the moment. We quite have a lot to cover, and we're going to take questions, comments, observations that pertain to what Prof has explained so far so good concerning the whole community rehabilitation worker thing, PPP, the MPU, the field, the shoes, everything. Your question should not go beyond the confines of what the topic that we are discussing currently is about. And we want to make it as short as possible. 1 minute each for every person is raising their hands up for questions. We will take four persons at a time. So 4, because I can see 10 hands being raised. So 4, okay, let's do 5. I can see 10 hands being raised. So 5, then Prof will respond to that. Then the other 5, Prof will respond to that before we go to the next agenda. So the first on my list here is it is Samuel. I can only see Samuel as your name here. I don't know if the hands have been raised even before Prof started talking. So I don't know, are you raising your hand to ask questions concerning the whole point in the discussion that we're having currently?
Yes.
Samuel.
Yes, I am.
It is Samuel. You have the
Yes, I
floor.
am. Okay. Thank you, Professor Rufai. So, firstly, my question is regarding the diploma. If the majority of physiotherapy community in Nigeria says no, we don't want this, and we are going to propose a solution and another solution, and also start fighting to get that act repealed, what will be the position of, what will be your position, sir, and the position of the board? Secondly, the comment you raised, the importance of physiotherapy in primary health care is very important. Humanity, and I totally agree. Now, sir, to the best of my knowledge, at least every year we produce between 500 to 1,000 corpus physiotherapists. If I'm wrong, I would like to be corrected. Now, corpus normally, if it's so important, the Ministry of Health and NYC can liaise and just post corpus to the primary healthcare centers. That alone is cutting costs and is at no cost to the ministry or to anybody else. Secondly, fine, we don't have the required number of professionals right now for degree, but the unemployed ones, in order to incentivize them to go to work in primary health care, if the salaries can be harmonized across board, so someone working in a primary health care center will also earn the same or reasonably close to someone working in a federal hospital or a state hospital. Then, if we start doing diploma, the quality of care that these people, the patients, the society will receive is not the same as the quality of care they will get from a physiotherapist. Are we saying that we are prioritizing quantity over quality? Are we saying we are condemning them to that fate? Then, sir, I was listening to you, and you've also complained bitterly about the lack of regulation and quackery. Sir, if we already have that, then how is it foreseeable that we should do something that will, in all most certainly increase the existing crisis we have when they've seen no solution to the one on ground? And then the issue of PPPP, sir, we have been talking about helping people. If we start that, it will be purely profit based with no care for the patient. Sir, this will be a non-humane approach. The companies, everyone involved with it will just be about the profit. So if we're actually talking about humanity and humane things to help the profession and help Nigeria in general, the PPPP is a non-humane, totally profit-based, and will most certainly be of no care to the patient. Everything will just be about what can I get from the hospital to what can I get from me. I don't care about the standards. I don't care about anything. Just give me my money. I set you up. I expect this return. This is the ROI I'm expecting. Some of them will even choose to even go for mid card because of course it's just all about the money. So that's all I have to say. Thank you, sir.
All right, thank you, Peter Samuel. Very quickly, over to you, Mo Josh. That's the name I'm saying here. Please, I would like us to be very brief with our questions. Thank you.
Okay.
You can drop your hands and mute yourself if you've been called.
Okay.
I can hear you, sir. Mo Josh, over to you, please.
Okay, sorry, I was speaking to myself. I didn't know I'd not muted myself. Yeah, okay. Thank you very much, Prof, for the information you have provided, sir. I would like to quickly say a few things in regarding what you said. First thing I noted from what you talked about was capacity to cover, and you did come out with data regarding how we could not match up the need of people in the community. Yes, you may be very right in that regard, but I would think that there are better innovative ways we could go about this rather than empowering quackery, because that's, to me, that's what I think we want to do. And I will make those submission very quickly. The first is I also listened to you while you talked about number of graduates that are being chalked out from universities. But one thing that is instructive from your from what you said, where they were more of private universities, and I think that is one thing that is common about them. But the reality is that as we have started chunking out people in DPT, if you probably make a national survey, the reality is that people are getting more interested in coming into physiotherapy, and and admission nowadays is even getting more competitive. I think we could probably improve our capacity in this area, probably getting to let more universities admit more students and produce more students. Uh, I'll also say that in terms of this building of this capacity, I'll also say that we should build in terms of number and quality. What do we also offer people after they have graduated? How do we ensure that people probably be able to get advanced in their practices so that they can do well in these spheres? That is it on that side. In the aspect of pathway, when you talk about pathway, I think one of the lazy things that we've been doing in the past is that we've been seeing community as a specialty. Community is not a specialty. Community is an area of practice. As much as we have acute practice, that is how we should have community practice. And one of the solutions to this is that, sir, you may have to find a way to liaise with hospitals, tertiary hospitals, and hospital boards. This is how I think we could start about this. We should have a community practice in such a way that we have all specialty areas in the community. The hospitals, when patients are admitted and they are being discharged, patients should not just be discharged home, at which they don't have follow-up. The hospital in itself should have a community practice in such that there are different specialties in the area of rehabilitation where people can go to, where physiotherapists could go into the community and visit the patient. They could have the community practice as well must be well integrated with the acute practice in such a way that information and data about the patient is being shared. This is probably a more robust one. I don't mind if I probably get your number in the long run, and I probably give you a call and be able to give a detailed information about this, how it's being practiced in other parts of the world. For example, I'm a community neurophysiotherapist in the United Kingdom, and I think I have a bit of understanding of how things are being done. But it's quite a broad thing to just be able to chunk out because other people also have questions here. The other part where I also have concern is the structure of supervision. We have primary healthcare centers already, and in my own opinion, if we in this pathway we are talking about, if we're able to structure it in such a way that the community support workers, where we cannot have them practice solely on their own, in the sense that probably just because they are limited to assessing, that is the scope you probably think we want to give them. But it won't work that way in the reality of life. In the reality of life, this will not work that way. So in my own opinion, I would think that what we probably need to do is to find a way where the scope of practice of which we've given them, where we say they just probably want to assess, there must be someone supervising them. There must be someone taking charge of the community practice. There must be someone taking care of what goes on day to day and reporting back to the hospitals, because by the time we probably just leave it onto the what do we call them, community rehabilitation support workers, it will eventually be messy. And I can tell you, sir, whatever you are trying to shoot in the good part today, in another decade you might probably regret where we are going. Another is the act that you've talked about. I don't think there is, yes, it might appear a bit difficult to say we want to review an act, but why don't we go that route? Why don't we, instead of wanting to enhancing the community support workers. Why don't we try and see if we could get the act review and do the needful regarding that? I think I will use the mic now so other people can ask questions. But if I have the opportunity to probably have a private conversation with you, I will really appreciate that, sir.
All right, thank you so much, PT, Elmo, Josh. You can drop your hands. PT Afolabi, yes, I can see your name was not deleted. I'm following the way everybody raised their hands up in order. So going forward now is PT Ifeoma Nwosu. After you, we're going to have PT Adebambo Adefarakon. That's 4. And the last person for the first 5 persons will have PT Divine Favor. Then we'll start the next 5. So PT Ifeoma, over to you.
Good evening. Thank you, my registrar. Uneasy lies the head that wears the crown. While I appreciate all your efforts in operating an open office, though we're humans and we fail in some regards, what I would want to say, going by the facts that you presented, I would say that every opportunity we have to talk with the government is an opportunity to increase the labor force for the employment force for PTs in Nigeria. I know that he who pays the pipers determines the tone that he plays. Why you cannot disregard what the Minister of Health says, the fact remains that you said it yourself. We have less than 8,000 physiotherapists. Can I know the justification why we should have unemployment at all? Why should we have unemployed physios? I think that should even be the bait, the number one bait. Why, if the Ministry of Health is trying to say yes, they want to follow WHO, then we'll recognize the fact that 8,000 is small compared to the population of Nigeria. So for that reason, it means we shouldn't be hearing of unemployed physiotherapists at all. If they really, if we want to say the truth, if we say that physio is very important, rehabilitation is very important, and I understand the importance of having support at the primary healthcare centers. You know, I've said it before progressing in my career, that when I first started, I've actually worked in the communities. And that is in Anambra State, because the governor then was Peter Obi, and he was able to employ physiotherapists. I mentioned all the specialists in all local government area. Why that is not possible in all primary healthcare across Nigeria remains unknown because of the way Nigeria is set out. But then again, if it is a necessary must, because we must begin to ask ourselves some right questions, because I'm not the registrar today, but if it is a necessary must that there must be some people there at the primary healthcare center, I have some suggestions. You know, I will always have. Number one, the problem is not making laws in Nigeria. The problem about law is implementation. And the problem is not just getting those people. The problem remains supervision. To be very honest, you know, I will always give my time. I'll be very, very happy to be part of creating that pathway if it's going to ever exist. In the sense that, because what is more important to me is the future of physiotherapy in 20 years. I don't want to be doing DPT in a program if I don't believe in that program. If I don't believe in physiotherapy in Nigeria, I won't be doing DPT. And if I'm doing DPT, I want to protect the future of physiotherapy. It's not just about the physiotherapists themselves. It's about the fact that it could be my aunt in that primary care health center. And we have released quack with documents, with license by my board. And they will go around parading. We already have issues of quackery we've not been able to deal. How much more the person you gave license? So what I'm going to say is, I understand your plight. The Minister of Health has said what he said, but I'm proposing that if it's a must, number one, we should remove rehabilitation from the name. It should be community support workers. Number two, if we elongate their years to 3 years, then it becomes competition. I propose that it should be a maximum of 18 months. And I can tell you that I've also been researching, and I have an eye there. I'm not saying it's perfect, but I definitely have an idea. Having practiced in Nigeria, practicing in Western Mode, and I'm also a community physiotherapist as well, and I'm in the community itself. So I have an idea again, just like Mojosh, of what exactly it is. And worst case scenario, I am dealing with the older adults. I work with older adults. So I think I have a perspective of this. And what these community support workers would do, I already have an idea. I can share it if you want that. And also, the specifics, because I see it as an opportunity to make demand. You know already that I like politics in a bit. The specific, the way we could make demands from the government, because we can't give them that without getting something. The way we can make mandate and say, for every 5 community support worker, there must be 1 physiotherapist, licensed physiotherapist, full-fledged physiotherapist managing it. And how because these are the modalities we must put in place. And also, we must also put in place a pathway of what, because everybody is ambitious. Even that support worker is ambitious. So if we have community support workers, we should tell ourselves the truth, because I'm a realist. I think about tomorrow. They will one day want to be physiotherapists. So as we're trying to create it now that we're answering Minister of Health, we'll also create that pathway that can land them to be physiotherapists. If someone is a community worker, we have trained for 18. If someone is a community worker, you've trained for 18 months, that you've trained for 18 months and is identifying and referring, identifying. In fact, I've gone to the extent of trying to create what their curriculum should look like. Who should teach them? It should not be only physiotherapists, so that they will really answer the name community support worker, so that they cannot replace physiotherapists. I could share all that. You know how I can be when I really want to do something. And secondly, when I'm talking about the pathway, if they decide to be physiotherapists, OTs in the future, I've also tried to also create a pathway how they can achieve that. If they have been support worker and they've graduated, they've worked for 2 years, the bridge program, how they can get into university, the same way we do direct entry, and get into BSc physiotherapy, and how they can go through the university and become licensed physiotherapy, just in case if somebody becomes ambitious. Because when we make that program 3 years, that long, the length of the program, the person will be like, what can you do that I can do? Then it become more difficult, this quackery. So I'm saying, if worst come to us, because I like to be a realist, and we must do this, it's best to remove that name, rehabilitation, community support worker, and they will not be trained by just physiotherapists. And I have an idea what their curriculum should look like, because it should have nothing to do with management. Because remember, when we're even trained as physiotherapists, if there's anything I knew as a young physiotherapist, my teachers will always tell me, identifying, not treating a patient is treatment itself. Because if you're going to treat that elderly person that we're all compassionate about, and you make it worse, have you helped them? But if the curriculum, if we're able to pilot this properly, that the curriculum stops the ability to be able to identify and say, yes, they've identified this case and refer, then it will be a win-win situation. If we stop at the fact that even the funding that will come to them will have, since we're trying to also protect, what I'm looking at is 2030, when WHO rehabilitation game is full. Who will help that department? How do we preserve physiotherapists there? If we can mandate now that it's in our court to provide this thing so that nobody does it outside, there are rules, there are things we have to put in place too. That's my observation. Let me just leave here, because let me leave it for other people to make. But sir, I'll reach out to you personally, because I have a lot to say on that. But what I'm saying is, this should be a bargaining tool for us. You know better than I know, and you're in communication with them. If rehabilitation is the hunger, what I should see is that the 8,000 physiotherapists in Nigeria are all employed. We should not be talking about unemployment. Then there will be now reasonable justification for us to be looking for how to support. And we should see why I'm insisting on pathway is that, so that community support worker cannot even be used, let's say for an example, even the doctors, to replace physiotherapists. Because why? There will be a pathway for them to become physiotherapists or become occupational therapists. It's not only physiotherapy that is rehabilitation. Occupational therapists are also rehabilitation. So if that pathway is there will be nothing to bribe them in the future. They will know the route and the channel to follow. So if we must do it, we must get it right. We must do it rightly. Thank you, sir. And that 3 years is too long, and that will lead to challenge and a lot of quackery that we're all against. I think I'll drop my mic here.
Thank you so much, PT Ifeoma Nwosu. You can drop your hand. I believe the registrar is taking note of all questions. We are also taking note so that we can know the ones that are going to be answered. We have coming up next is Dr. Adebambo Adefarapon. For everyone on the YouTube stream who have asked a question or the other, drop a comment. Be rest assured that after the first 5 persons have mentioned and come up with their own questions. We will read out yours also to the registrar. Keep your questions coming up on the YouTube stream. Keep your comments. Keep everything coming. Everything will be read out to the registrar. Over to you, Piti Adebambo Adefarapon. You have the floor. Let's keep it short and simple. Thank you so much. Adebambo Adefarapon. You have the floor.
Hello, I hope you can hear me.
We can hear you, sir.
Okay, thank you. Thank you very much. Good evening, our dear registrar, and good evening, the colleagues. I thank the organizer of this program. Not to take our time, let me start from the statistics that and the act that registrar mentioned. And before any act can be drawn in a particular, case, that shows that case is concluded. It's done and dusted. It's concluded. So, and let me start from the because registrar start from statistics, Prof. The statistics in Nigeria, we have 774 local governments in 36 states. And in FCT, we have 6, making 768 in total. Medical and Dental Council combined together, they have between 85,000 registrants. And presently in Nigeria, only 55 are practicing medical doctor. So if we have 768,000 total local government that we have, and 55,000 doctors, and the same doctors sat together and form an act that because we want to cover the community, that the other professional should train a lower cadre of, practitioner. I want to know, please, do they ask the medical doctor and dental doctors to dentists to also develop a low cadre so that all the places can be, covered? Nobody is left behind. You see, I've not seen the act, and I would love if we can, because if it's a act that have to do with us, they should circulate it to us. Let's know the role individual plays in that regards. Then I have studied the PCH, primary health care, centers, community centers. I've studied the core principle. Number 8 of the principle is health as a human right for all. So you are very right that every nook and cranny of Nigeria should be adequately covered when it comes to rehabilitation. The number 2B of the core principle talk about equity and the oath that all of us, sworn into, that which you are, going to do tomorrow for what the assignment you are going for in the East, stated that every Nigeria must be treated equally, irrespective of religion, cultural, and economic status. Now, if the act now suggests otherwise, because we are not less practitioner than doctors. In fact, in some cases, the condition we manage you understand, as a physiotherapist, it needs a serious expertise. Just like we have a patient that had, fat embolus, have a DPT in the town. We also have them in the village. So if we now say because of my own mother and my grandmother in the village, we want to train the less experienced, less equipped to go to the village without any supervision, to be the first contact there when it comes to issue of physiotherapy. Are we practicing what we swore into? Is that not double standard? That is totally against the oath that we swore into. And the issue of coverage, we have talked about this thing. I've been practicing for many years, both government and private practice. In fact, on the issue of PPP, I think I am the first that started it in Abuja here, in CBN, which I later established a very big clinic there that they employ more than 7 physiotherapy. And, in Abuja, then they establish, to the other country. So if we are talking about the coverage, the only sustenance coverage we can think of now is youth service, NYLC. Somebody have said it before. When we end up training a locator, no matter the nomenclature we place on it, you cannot put chain on them that they should stay in the local. I have an experience with many hospitals here in Abuja of an hospital that are using even ordinary nurse to carry out physiotherapy treatments in their hospitals. And I can tell you, if we end up doing that, once one community trained license come to town, they will take over all the physiotherapy job. Nobody is afraid. Aristotle said, if you want to end a profession, you don't need to just go and push the people that are not well trained outside, allow them to practice profession. In so doing, they will mismanage, they will cause havoc, and the old news will go that, they won't say they are less trained, is physiotherapist profession. From there, the profession will lose their, reputation, and they will lose their face in the society. We have a lot to lose when it comes to this. Because if we start, registering them, I can tell you in 2 years, no, let's say in 5 years, they will graduate the number that will outnumber the present physiotherapy that is on ground. And I can tell you, 99% of hospitals would, rather, I'm talking of a private hospital, will prefer to take them because they are licensed by the same board that licensed DPT. I was talking with somebody because we have to be very careful. We have to look at the future of what we are trying to establish now. This is a place we have left. And I can say all the profession, there's no profession that doesn't go through what we are going through now. Every profession, from doctor to dentistry, we all started by diploma. And immediately they phase out. None of them ever come back to the issue of diploma again. Diploma, none of them, not to talk of the physiotherapist. We are now, many of them are pursuing DPT. And we know how difficult it is. And for us now, to now think of, you are now competing, anybody that is talking of fear, it's not the fear of individual, it's the fear of the profession. I want the registrar to look at, it's the fear of the profession. Nobody can take that thing away from us, but the society can take it away from us. And it will affect both academicians and lecturers. Because if my daughter, I know there's a lot of quack out there, nobody will allow their children to go and study physiotherapy. They will go for another thing better. And this thing is not only affecting the physiotherapists. I had a talk with prosthetics and the other professions, and none of them, they are very skeptical. They are not happy. And the voice of the people is the voice of God. People have spoken. Because of this, we don't want to jump into anything. We come together that, okay, let's even hear the opinion of majority, mainly physiotherapy. And within a year, we put out what they call it, petition. Within 3 weeks, we had 1,552 physiotherapists say no to the diploma or whatever the name, any lower cadre. And I can tell you, we're in democracy. Nobody, even minister, cannot voice it on us. If all of us come together, that we don't want that. So let them start, you understand, if they want to make it an art, let it be a total health coverage. Let it start with the doctor. If they give you their own statistics, you'll be amazed that they don't even have the number that we have now because of their wide coverage. And they are not considering, the doctor will tell you, if they remain one in Nigeria, they will never lower the standard. They will never lower the standard. And if this thing is totally for the love of the profession, not because of the gain, that somebody wants to open a clinic to do this thing, to train, to be part of training and whatever, whoever that love this profession. I love the profession. It made all of us what we have today. So nobody should talk about, nobody's afraid. We are all professional. If Nigeria is not good, we travel abroad. But we have decided to stay here, and we will do it. So, in a way, to give the other people space to talk, what I want to know is that I like the physiotherapy. I want to appreciate you. I want to appreciate the registrar. We are practicing true democracy in physiotherapy. I can tell you, we are practicing true democracy. But let me stop by this. If any NMA president or local or state leader in NMA make this issue as a joke, I can tell you that person will not stay longer than 24 hours in that place, because the whole profession, the whole doctor, they will go after that. But the fact that we are very, diplomatic person, you understand, we want to, still see ourselves as one. That is why all of us are talking this way. It's not that if if the board or anybody, even minister, decide to voice this on our throats, we know what to do, and we'll surely do that. We'll say no to. I stand here to say, please, Mr. Prof, please help us to reconsider. Tell the minister the act is not complete if it doesn't involve doctors, dentistry, to also train, because they don't cover all the community. Thank you very much.
Thank you so much, Peter Adebambo Adefarakom. And please, to every other person who will be coming up to speak, let's ensure that we do not go over what someone has said. If someone has made the points that you want to make, someone has said it ahead, please, you don't have to go over it anymore. If someone has asked the question you want to ask, you don't have to ask that same question anymore. Please, let's try to manage our time. We have just 1 minute each for every person who wants to ask a question, raise a comment, or observation. The last person for the first 5 set of persons, PT Divine Favor, over to you. You can drop your hand, PT Adebambo Adefarakom. Thank you so much, sir. Divine Favor, you have the floor.
All right,
Please,
thank you
let's be
very much.
fast. 1 minute each. Thank you.
I will try and be fast. Thank you very much. Thank you so much again, once again, Prof. And thank you everyone on the call. I will start by one thing I know about rehabilitation as regards to MRTB is that the modus operandi of the board is also to raise the bar of the professions under it, and to global standard. And I believe that even before the 2030 World Health Organization agenda, there's always been an agenda from the board that every physiotherapy should transit from degree to DPT. So us going back to diploma is like regressing our steps, and it's not advisable. As regards to the acts, I don't know if there is a way. Somebody have asked that, anyways. I don't know if there's a way it can be reviewed. We hope that if there's, we can need to remove it from but let it not be there, so that it won't be an issue in the future. Then I want to also believe that the major concerns that I've heard from you, Prof, is that is the issue of lack of identification and referral, or the work of whoever that is going to be in the PHC will be more of identification and referral of rehabilitation cases. And why most of the physios are clamoring against it is because of the dangers thereof. Dangers in terms of the regulations. I'm in Abuja currently, and I know that I didn't, the first time I even heard about the issue is where I went to do PP, and the next seeing my client was also issue, and he works in at FMC. That's to show that's show how quackery can happen in this country. So the concerns of people are also valid on that. So and if there a good strong regulation has been on ground and there some things are being introduced, people will no longer be afraid of that. Dr. Ifoma, my chief, mentioned something about instead of calling it community support workers. I think that's the fairer and safer, or I wish the word is, to make sure that people don't abuse their boundaries. Then as regards this community support workers, like she said, that's what we have to also understand that it's not just about PTs. We're also looking about OTs. We're also looking about speech audiologies, because this is the rehabilitation per se. So I think we should also look at how, because I understand the fact that, Prof, you are coming from the government as perspective, and whatever that you are going to present to the government, it also has to be counter-reactive to whatever data they are going to produce. So everybody is clamoring and saying that we have 774 local government and how many thousands of PHC. But do we have a data of how many of these PHCs are functional in this country? I believe that if we have a data of how many PHCs are functional, how many PHCs are in a cluster, if we should do it by cluster, I think the former registrar also pointed that if we can cluster it maybe in a local government, to have like 3 or 4 clusters. Now, not necessarily are going to the PHC is going to cover all the PHC, but if 5 PHCs are together, one of the PHC can be the cluster points whereby people can access physiotherapy service, and it's cheaper, and it's also within their transport means. So working with the clusterization can also work in terms of having PTs available. Then we can also look at I did my internship, we did community posting. I know students also do community posting. We can strongly build that on that as well in terms of internship. And also somebody mentioned about corp members have years. I think I mentioned this as regards to the last time we met in the board. this issue of harnessing the corps members, know the number of physiotherapists that are in each batch. When we have this data, it can help us to have a plan on how to tackle the availability of service. Then, even if we need the means of identification and referral to rehabilitation service, people that will be on ground for that, like Dr. Ifoma said, we can have people that are trained 18 months or so in the various rehabilitation courses that will be able to identify and also refer appropriately in those clusters, in that point of cluster, LGA cluster point, that, they can go and see a physiotherapy, they can go and see a speech therapist there. And even if they want to do they can have different days for different occupations. Maybe physio will have Mondays and Friday, or speech will have the other days. So it can work if we look at it that way, especially if we have an idea of a working the working PHC. And just like also Dr. Ifoma said, if the government is arguing about 8,000 that we are 8,000 physios or so that have been graduated, that means nobody should be complaining about not being employed. And the truth of the matter is that where I stay there's also a PhD there, and it's in town. So people can work there, and it's just like me going
Let's round up.
now. Okay, Marga. Then in all of this, I believe that partnership with the institutions, with the professional bodies, and all of us can help us get the data and can also help us plan and know how where to tackle this. And then most importantly, we need to champion advocacy and awareness creations. If therapy departments can begin to do community outreaches as it's like a must per se, it will go a long way. Community outreach will go a long way in alleviating some of these issues, which is awareness creation. I think I'll just have to end it here. I'm trying to rush everything at the same time. Thank you very much. Please, you have the floor.
Thank you so much, Dr. Divine Favor. Thank you so much for your question, your comment, and your observation. You can drop your hand. Before the registrar come up, I just want to read some of the comments we have on the YouTube stream out so the registrar can take note of it and merge everything together. Then we take the registrar's comment to the first 5 persons, and then we go again for the next 5 persons. I'll be reading only comment that has to do with the current discussion that we have on the call at the moment. Someone said diploma is good if the workload is too much for physios. Now, physios don't even have jobs, so the diploma is for what? Who started the idea, and what will they be doing when even physios are jobless? Another person said, with due respect, our dear registrar, sir, regarding the issue of diploma in physiotherapy program, there is currently a high number of qualified young physiotherapists who are unemployed. Another person said, I believe that a more sustainable way forward is to create more employment opportunities for these professionals by accrediting additional physiotherapy departments in hospitals where such services are not yet available. This approach will not only provide jobs for young physiotherapists, but will also improve access to physiotherapy services and enhance healthcare delivery. And the last person I'm going to read his comment or question said that diploma in physiotherapy when physiotherapists don't have work. Let me just make my money and leave this profession for you now. What is the CHIL statistics in Nigeria, and how effective has CHIL been in covering the PHC per state in Nigeria? What is the board stand with the Postgraduate College of Physiotherapy? How about a compulsory paid internship in community health? Community rehab sounds better than a diploma in physiotherapy. We don't have a diploma in medicine. Universal health coverage, in my opinion, is not just increasing numbers, it is also strengthening the available infrastructures. If the places are attractive, physios would go. In any case, crew supervised by physiotherapists. So I would like the registrar to react to some of the questions, all the questions being asked so far so good, the comments and all. We have the floor, sir, registrar.
Thank you very much. Thanks a lot, everyone. Thank you, thank you, thank you. There is a meeting on the Chobdin platform, and I know currently they're also having a meeting. You know, at some point, because it's a group of directors and professors, I thought I was on the same platform. I had to check very well whether it's the young physiotherapists, because you guys are just schooling me today, and I truly, truly appreciate you. So no one should call me prof again until the end of the session, because it seems like today I've become a student. But thanks a lot. Let me just give background information before I address this. I'm not going to address this as if I'm just defending a position. So where I agree with you, I'm just going to say I agree this should be done. But while going forward doing that, I believe in when we discuss and bring out issues, especially those issues that need to be addressed, that we begin implementing them. I mean, many of the things that you have mentioned, notwithstanding whether there is diploma or no diploma, there are things that we need to do to advance or improve if we have them all. So I would like to plead with all of you. I've dropped my number. Someone asked for my number. I've dropped it on the chat forum. Feel free to reach out to me. Just give me an excuse if I don't answer calls because of activities or I don't reply. Send me a WhatsApp message. And I also want to plead with you that if you have any idea, just like some say they have documents, they have many ideas, if you can package it and recommend others that can form a committee to develop it to the extent of the implementation, I will appreciate that, so that we don't just mention them. I know it's not possible, all the things that are on our desk, to be able to approach everything and do them within a short period. We need support, we need hands in. So that just as a background information, but I will go through some. I will just give clarification. That doesn't mean I'm defending any position, but just because if I have information that I think I need, that those that I just need to say accepted and considered. The issue of majority of PTs not wanting this. What do you do as a board? Remember, if you were there when I started discussing or explaining these issues, I said there wasn't any single thing that was my own. I mentioned the issue of meeting in 2023 where people agreed that this should happen, but how it should happen, we didn't know. Someone came and said, this is what we should do. Okay, form a committee. The committee made recommendations. We went to here, we went there, we did stakeholders meeting. At the end, what was agreed was what was initiated. So if you have anything that's superior to that, that should replace that, if you bring it, it will be accepted. And remember, I also mentioned that after the series of stakeholders meeting that we are going to have, I'm going to write to the minister and ask that the minister send a representative to the meeting so that whatever issues we have, in fact, if you chair the meeting, I will do that, so that let people present those proposals. We don't want this, we want this, this is how we want it, so that let the ministry take note of all those things. And then that will be the position. It's not about me. I'm just there in between. There's someone that approves things for implementation. Mine is just to look at the act. What does it say I should do? And that's what I'm doing. So I assure you, whatever the majority want, it will listen, take it to the higher level and see if it will be approved. And you'll be there when the higher level will tell us what they will do. Because we'll call for a meeting of representatives of this group and many other groups, and we'll meet with the representatives of the ministry and present whatever it is to them. 500 coppers. Inform ministry to start, even though it cannot, or it may not cover the needs. So, but of course, the 500 coppers, very important. I agree with this, but remember, we are developing a national rehabilitation policy, which never existed. So, we are going to call for stakeholders meeting on that. Situation assessment has been completed. WHO is helping us now to come up with a strategic plan with our own input, of course. So I think these are some of the things that can go into the national rehabilitation policy. If it's there, ministry will just send a communication to NYSC, and NYSC can consider that and send. But the only problem is that if you have that number, and we are talking of huge need out there, it's not going to cover that. You know that, definitely. So, but it's a good start. Let's start with something. But another thing also is that with the influence that parents have in Nigeria, many people will be sent to the primary healthcare centers, especially in remote areas. Their parents will draw them back to the cities. So that also is something that we need to look at. Rising salaries, as I've said, national rehabilitation policy is coming. See, let me tell you, one of the reasons why medicine, pharmacy, nursing, and medical lab get a lot of attention and get funding for the things that they do is because all the four have a national policy. I know this because I went to the ministry and I asked, why is it that whatever fund comes, you push it to these few professions? And they told me, if government gets funding, and I'll give you an example. One day in Senate, BUK, when I was acting HOD, someone just called the VC. It wasn't picking calls in Senate, but that day he picked and he told us. He said someone wants to give the university 250 million. But he said, do you have a plan on ground now that you are going to immediately implement? And he called director planning and he said, bring that plan for computer and information technology something. There's already a plan. Everything has been prepared. He now sent it. The money came. Right now, that faculty is there. Whenever I pass, I see it. I remember that Senate meeting. So if you have a policy, when funds come in, it's easier just to direct it through. If you have a policy, when government is developing a budget, they will use that and say, okay, where is it that we agreed at National Council on Health that we are going to do this? Okay, let's put it there. So I'm not saying when our own policy comes up, it's going to be just as easy as I'm saying it. No, I'm not saying that. But I'm saying it's a step that people in government will be able to consider profession or professions if you have a policy. So I think this policy is very important to us. Before we finish, if we have time, I can just share, just so that you see briefly what the situation assessment report looks like from WHO. They sent it to me earlier today. The issue of quality of care, someone mentioned, if in the city you have DPT, why are you sending community rehabilitation workers to the village? And as I've said, sometimes I just want to give clarification. Let me give you an example. There's a homeless person feeling very hungry, as if he's going to die. And then someone is eating sugar cane. You know that part that's very hard, that he doesn't want to chew. He just throw it into a dustbin. And the homeless person just rush to pick, at least to eat, so that he wouldn't die. And then a nutritionist by the side say, hey, that thing will cause diarrhea. Don't eat it. There is shawarma and suya joint down there. You go there. Then you say, oh, can you buy for me? I'm a homeless person, don't have a penny. Can you buy? Say, no, I'm not going to buy it for you. But don't eat that because it's going to give you diarrhea. So to the homeless person, what he's after is to live, not to die. If he has diarrhea, maybe he will handle it. Maybe it might kill him. Maybe it might not. But at least. So this is the issue to the person living in a rural area. What he's saying is that if you are not going to give me DPT because you can't come to where I am, and I don't have money to come to where you are, and this is not surgery or drug that you come take it and then you are asked to come back after 2 months. In rehabilitation, is something that you do often, and it's also the other way around, something that you integrate back into the community, and therefore it needs to take place in the community. And the DPT is not going to the rural area. I went to see my father's friend that was living in a very remote area. I had to park, cross a river, and went there. So if it's difficult to go there and live with them, and they can't come out to meet you, then what do you do to them? Say, okay, just stay with your problem, your disability, because we can't send DPT. So I think this is, I'm just playing devil's advocate, so that when we are talking to government, we tell them something that they will really see as something that they should consider. And that's why I'm saying this, not to defend anything, just that let's play the devil's advocate. What will they think of the things that we are presenting to them? Lack of regulation and quackery, I admit, I'm registrar of regulation. I admit there are serious problems with regulation. But we can make them better. And this is something also that I've said, if I explain how we can make it better, it doesn't mean that we are saying, oh, we should do diploma because we can. No, even if there is no diploma at all, we need to strengthen regulation. And I've already told you some of the measures that we have taken. The issue of establishing surveillance volunteer program. Some have been helping us, but of course, they have been discouraged because of the fact that there's no governing board. But I've told you the efforts that we have made to see that in the future, even if there is no governing board, minister appoints those committees so that work will continue until it gets to the final stage. I've also told you we have a portal now, which will be launched next month. And that portal, wherever you are, you just open our website, you click the portal, you enter, you drop, and it comes to us. And we go to the back end, we forward it to the other committees, all on the platform. And at the end, you can go back and see how it has been disposed of. So also, as I've said, working towards expanding the funding base of the board. because regulation, especially inspection, is something that, as I've said earlier, you don't ask people to pay. And therefore, you have to get the funding to be able to do it. So PPP, profit-based. As you were saying it, I just thought maybe you were not there when I was presenting PPP. I said, this is not companies coming into establish. I think I emphasized that. I gave example with myself, with the Nnamdi Eze, and now I'm very happy. Our elder, Dr. Ade Farakon, has mentioned that he also had done it. But what are the problems Dr. Nnamdi Eze faced? Because both of them did it as a business. I just did it as a corper. I just wanted to finish his service and go to university and start to. So for the two of them that did it as a business, what were the challenges? This is not something that we are forcing anyone, because it's an MOU. If you decide not to sign, nothing. And I assure you, we are not pushing this for companies to come in. There is a possibility companies may come in, possible. But how do we mitigate those things? If we think it cannot be mitigated, nothing, let's leave it. Because for me, it's not about giving services to the hospitals. There are other ways that services can be given to the hospitals. It is about helping the younger ones. That we said there is no employment. Now, with the issue of rehabilitation policy, budget line, we are going to see an increase in the number of employments. But in the interim, before that policy gets to the point that it helps to increase the number, what do we do with our younger ones? That was the idea. But if we think it's not going to work, sincerely, let's push it. There are other professions that have agreed. About 3 professions in the medical rehabilitation, they are happy. They said there are problems, but let's make sure the MOU addresses the problems and let's proceed. So, but if physiotherapists don't want it, sincerely, that's very okay. You can leave it, because no one is going to force you to come and sign any PPP. And if you say you don't want it, I assure you it's not going to happen. People interested in DPT, medicine still not provided. Oh, well, I said many people interested in DPT, but I think Mr. Abdel Farakan has given the statistics for the medical doctors. Of course, around 90,000 registered with the MDCN, about 55,000 practicing in the country right now. But still, they have not been able to cover all the nooks and crannies. And that is why they came up with the CHU, Community Health Extension Workers. When Olukoya Ransom Kuti wanted to bring it, they resisted. But he insisted that it had to happen because of the communities. And up till today, you don't see medical doctors in those remote areas. It is still the CHUs that are good. So it's important. DPTs continue to increase, but as they increase, the needs in the urban areas will also continue to increase. And therefore, you still have a gap in the communities. So, I mean, if it's going to cover, we can produce the right number to go into the communities, no problem. But if you can't do that, then let's come up with an alternative. And as I've said, whatever is on ground now, you can come with an alternative. We can present it to the stakeholders and see what happens. Get advanced in practice, very important. I mean, younger ones. When I was doing my NYSC, my roommate is the husband of the current Minister of State, City. He's now an orthopedic surgeon. While we were doing our NYSC, he was studying for his primaries. I think he sat for his first primaries while we were doing our NYSC. So, but our younger ones now don't have the opportunity to do residency program. In fact, I know in the PPC, at the moment, you need to be 5 years after graduation for you to be able to get admission. Of course, the reason being it's the only one we have. There are so many older ones that have not done it, and therefore that limit is there. Maybe also let them get experience before they get in. But if medicine is having people at NYSC doing their primaries and then starting the residency immediately after primary NYSC, we need to be able to allow them so that they can advance early before they get older. And that is going to help. And I agree with this person that says we should advance. That's very important. Community net area of specialty. This is a very brilliant one. I agree very strongly. Everyone should go in. And that is why in the review of curriculum that we did, the issue of community is there as a posting, and you must do it. My number, I've sent my number. Structure of supervision, I agree. As I've said, it's not everything that I will explain. I agree very strongly. But these are some of the things that if you have enough information to form a proposal on how to do the supervision, then you can now advise us to set a committee. You do what you do and submit to us, and we'll begin to see where to go to begin the implementation. Review of act is very possible. But the only thing, as I've said, devil's advocate, can't go and tell government that just well, I don't want to say just, don't see it as insensitive, that because it's going to affect the prestige and also the issue of quackery coming in, issue of government cheap labor, that's not an argument that government will really relate with. So you need to come up with something that can really convince government that reduce, because you have a National Assembly person, he goes to his constituency, and that the people of his constituency, they don't have enough requirements to do a degree program. And there is a diploma program that is there, that is possible, and they had that he voted on killing that. He's going to be very afraid of doing that. And that is one of the reasons why they don't remove things from us. So you need really a very convincing thing that will really allow members of the National Assembly and the federal government to agree on repealing. Very important, but you can do that. The brilliant ideas that you're putting up here, if we form a committee, because I can't be part of that, I know you can understand that, but I know you as stakeholders can do that, make a submission and have it removed. It's very possible. Many people have done bills, got a National Assembly person and given it to him and say, please sponsor this for us, and put in some funds to be able to sponsor that to happen. So it's very possible, but then devil's advocate, think of the things that they are going to not agree with and make sure that you don't present it from that perspective. Level workforce to increase, I agree. Rehabilitation policy, sincerely, I'm counting a lot on that. As I've told you earlier, not in this forum, that when we had the stakeholders meeting, Ministry of Budget was represented. The minister himself sent someone. And when they went back, they reached out to us when we sent them the communique. And they said, when you get to the point that you want to discuss budgetary matters on this rehabilitation, reach out to us. So the time is now, because situation assessment has been completed, a strategic plan is being developed, and policy is already, draft is ready. Strategic plans. The moment we have that, we'll go to that. And I have a strong belief that we are going to have something change when it comes to the issue of budget line for rehabilitation. Problem about implementation of policy, I agree. We need to work on how to strengthen implementing the policies, not just develop. I agree, I'm not going to say anything about it. Remove rehabilitation from the name, I agree. So after the stakeholders meeting, all MDTE, and let them know. And I've told you, they said whatever name you give us, you are the practitioners. The only thing is that they will have some principles. So if they think they might give the principle and say, if you don't go out of these principles, we accept. And I agree very totally, because I was the one that told them. I said, well, people are saying, let's change the name physiotherapy. I didn't say rehabilitation to them. I said physiotherapy. But now that even the rehabilitation is coming up, let's present it to them. If they agree, they change it, because we changing it is not enough. Because someone is going to have a certificate that reads it. And therefore, you come to the board, there will be confusion if you are now changing it at the board when their certificate of that they got from the institutions is reading something else. So we have to carry them along. 18 months for the program, I agree very strongly. But let's also give justification to them that will make them agree, because we are not the ones that give the timing alone. They also give. And we can't go and change it to 18 when they are using 24 or more. So we have to both agree so that will not cause confusion in the institutions. One is given less, one is given higher. So we need to convince them. Ratio of professionals to workers. The national policy can take care of that. So let's include it. And I've taken note of this. I'm going to put down all the things that you have mentioned to the team working on the national rehabilitation policy, so that let's include them. The moment National Council on Health approves, it becomes a working document owned by all the states and the federal. So this is something that's really very good. No treatment at all. I've told you earlier, there is no treatment in the community rehabilitation worker proposal that is being developed. Well, the statistics, doctors from ACT train other cadres. See, when you talk of physician assistant, is it not nomenclature? They were clever not to use that nomenclature, but they have included it in this. And in the act of the MRTB, it doesn't say physiotherapy diploma. And that's an important thing for you to understand, that reviewing act is to remove diploma completely, if that's what you want. Removing it, that's when you go and review act. But if you want to change name, you don't need an act. The moment you have a discussion with MBTE and you agree and the name of the program changes, you can now, it's easy to now write to the minister and say the regulation that has physiotherapy in it should remove physiotherapy, replace it with what the professionals want. And that would be an interim thing, so that while you're working towards reviewing the act and removing the diploma component, if that scales through, then at a later time, that can go. So, but the issue of physician assistant is not there because they have someone that is doing it. At the community health extension workers, they are the ones referring to physicians. And when a physician sees a patient, he assesses, diagnoses, set the prognosis, plan the treatment. Does he deliver? Does he give injection? No. Does he give the medicine to the person or the drug? No. The nurse will do that. So that is the middle cadre for the physician, and the pharmacist is the middle cadre for the physician, not the pharmacist, the pharmacy technician is the middle cadre for the physician. And therefore, with that clever way, it's not. So if medical application professionals, since it's in the act, want to change and do similar to the physician way, it's easy. And as I've told you, MPT is very ready to do. If you want it initiated, it can be initiated. And as I've said, board can pay. The only reason why it can't even come in the next few weeks is because we are going to have another WHO meeting for the strategic plan. And it's the board that is taking care of the funding. And therefore, I can't guarantee we can put in fund. But if you want, set up a committee. Let the committee discuss and come up with selected terminologies. The moment we finish that stakeholders meeting, we can be able to reach out to NBTE, change it temporarily before the issue of review of act. A training less experience. Let's get about impact.
Mine is big car, mine is not little car. You need little car.
Sorry, someone is speaking. And please, the organizers, if you want me to get faster or stop at any time, just let me know. I'm trying to be fast, but I don't know how you still want it to be. Yes, so someone said training, they don't have enough experience. Why send them? I think I've explained that about the issue of the homeless person that I gave example. But I think another thing we can do, let's find out, have CHUs made an impact at that level, or have they not made an impact? So if they have made an impact, what made them to make an impact? How can the lessons be learned in giving rehabilitation in the communities? So let's do that. Let another team take this and find out. That will help us to be able to advise government to say that, look, there is no need doing this because they are even killing people more than they are saving them. But if they're saving people more than they are killing them, then that's because you can never have a perfect system. You must weigh and see which one is just like drugs. They have side effects, but you don't stop taking it because the side effect is less than the advantage. We have cars. Every day they have accident, but government has not stopped the importation of cars. Why? Because I came to Okigwe from Enugu in a car. If I was to walk here, how many days will it take me before I go back to MRTV? So these are some of the things that government will want to listen to, things that will challenge their thoughts. PPP, not just about coverage, but employment. Yes, I've mentioned this earlier, that the idea about PPP is not about coverage. The other issues that we have discussed, middle level manpower at the community level, that was about coverage. But for the PPP, it is about our colleagues, especially the young ones, getting a space that they don't have to pay rent, they don't have to do advert to get patients, and they get something, and the hospital gets something. At the end of the day, the advantage is that the hospital, when they are leaving, will have something to continue, just like Guru had when I left. And the advantage to the young physiotherapist is that by the time he gathers enough to establish his own, will now be able to have a foundation to move out and establish his. NYSC, sent to PSC's influence of parents, I think I've mentioned this, produce number higher than PTs. Well, regulation can help that. If that's the route that we are going, you can be able to say that this is the percentage. And that's where the national policy can come, that you can't have more than 5 to 1. And therefore, if this is the number universities are producing, if you have institutions doing diploma coming up with that number, going beyond that ratio, you can say that you have stopped, that no, we are going to not create any until the universities produce more. But we have all agreed, regulation is not strong. We need to strengthen it. And these are things that we can to work on. Whether that comes or not, regulation is important, as I've said. Advance the profession. I think I've mentioned this. PPC needs to open up for younger ones after 10 years of having a policy that you wait for 5 years before you get admission. This should now change because we have many people that have been produced as fellows. And another thing, there's no way you can do 1 week or 2 weeks of hands-on in a year and you'll produce someone that will compete with a resident doctor that day in, day out is with a supervisor in the clinic working. Never can produce someone that can match that. So we need to begin to think. I mean, it's easy, it's not too difficult, because I see people, for example, Professor Igwe go to Ibadan, and 10 or 2 or 3 or 10 fellows will also go to Ibadan. In the residency program, it's a specialty. If I have a supervisor, it's like a PhD. I'm the only one that supervises my students. So why should they travel to another state, and then me also travel, pay money, they pay money, and then we go there and we do training? Why can't we just do it where we are? If you have an MOU with a private clinic and say that this fellow and his 2 students will be coming in once in a week, they will be seeing the patient in his presence, and he will supervise them. At the end of the day, he clears them, they get their fellowship. It will strengthen the process. But I think it's something, that's why all these fights that we are having, I've said it. I said, if we sit down and we discuss these issues, we'll grow. But if we just are fighting each other on things that are trivial, we are never going to go anywhere. So it's in our hands. And that's one of the things that I keep saying. We can't wait until things change, because we are the one that will initiate the change. We are not ready to initiate the change. Why should the poor man in a rural area suffer because we are not ready to do the right thing? Number of those in petition. See, let me tell you something. If this issue of diploma only affects physiotherapists, the issue of PPP, I told you, even though there is need for providing services, but primarily the idea came because we want to help the professionals. If the professionals, majority say they don't want it, we are not going to do it. The majority carries the day. We move forward. But when it comes to the issue of providing services to rural areas, you have over 100 million people that can potentially need the service. You have just less than 4,000 practitioners in the country now. And when you do sampling, you do a sampling that considers the number. Out of 3,000, maybe you are taking 500 as a sample. Out of 100 million, or let's even say 30 million, just number of people with disability, not just all that are requiring, requiring rehabilitation. Take 30 million, take 3,000, take a sample of 3,000, take a sample of 30 million. Do your petition, your voting. Let's see who the majority will be. So if you take, that's why I'm just looking at it and I'm laughing. I said, so when you finish, where will you take it to? If you take it to ministry, or you take it to police, you take it to court, you take it to whoever it is, the first thing that anyone will ask you, who are the stakeholders? Okay, let's call the other stakeholders apart from you. In fact, they are the biggest beneficiaries. So if they are the beneficiaries, you take the poll and see how many of them will say, stop diploma. We don't want these physiotherapists to be affected, their prestige, their salary. When I'm feeling hungry, I'm going to die. And you are talking of quackery. I'm thinking from their perspective, not from my own as a physiotherapist. So CHOOS have been helping them. I told you how many people came into a clinic because CHOOS sent them. So it's the same person that you go and say there is someone similar to CHOOS. Discard them, don't do it. Say, oh yes, petition. No one should do diploma. No diploma, no diploma. Let's think very well before we present this to government. Devil's advocate. Thank you so much, sir, for being diplomatic. I appreciate that. And I've apologized earlier if you are not there. I said I apologize if I wasn't diplomatic myself. I'm very sorry. And I appreciate that people are diplomatic, and that is why we are having this discussion. When you talk of dentistry not having a diploma, see, dentistry has a diploma. In our board, the only profession that has 3 regulatory bodies is dentistry. You have MDCN, you have dental technology, they offer diploma. You have dental therapy, they offer diploma. But that is not to say that we must have one. But what I'm saying is that if these are points that we are gathering to go to government, they are not going to pass through because they are going to give you the facts. And that is what I'm trying to do, devil's advocate. MRTB taking profession to global standard, stepping back. See, as I've said, you are producing DPT, people in the urban areas are benefiting. Someone in the village is not stepping back. It's for you that you think is stepping back because it's not affecting you. But let me tell you something. In your house, if there is someone that does not have admission through degree, brother, sitting there, he does this. It's to you, you say it's stepping back. Now, that is not to say I'm insensitive to the fact that if they come in, there will be a menace. But as I've given example of other life endeavor, like cars killing people, they are still there, managing the effects. road safety is there, VIO, they are not doing a good job anyway, but this is still there because the citizens need those services. So if you are talking to government and you say stepping back, Minister is going to ask you, okay, how do you mean stepping back? And you are going to speak from your own perspective, and he will tell you there are 30 million people out there. How is it stepping back to them? So I think, as I've said, I'm not defending anything, but I'm devil's advocate. Think of what you are going to present to the authorities. The act can be reviewed. I've mentioned dangers of regulation. I agree. There are. Can we tackle it? Whether there's more or not, we need to work on it, and we need your support because you are the volunteers that are there looking at what's happening, reporting to us. But apart from that, any policy we develop and we implement, we'll do it with you. We need your support. Community support worker, I agree. Let's talk to MBT. How many PHCs are functional? Please, let someone help us get the statistics and the information so that we can use it as we move forward. Championing awareness, I agree. Doing community outreach is good, but WHO is discouraging community outreach because it's a spontaneous thing. I had a discussion with Dr. Nasib during the meeting, and when someone mentioned community rehabilitation, he said that is what WHO is advocating, that community delivered. They are there. They are doing it day in, day out. Not that you come in this week and you go back until after 6 months you come back. That is what WHO's position is currently. And you can reach out to WHO and get that information. PTs not have job. Why diploma? Well, that's what I've mentioned about the issue of the policy. If you have a policy that gives budget line, you are going to move an inch towards solving the problem. And then we are talking of PPP, we are talking of businesses. I know about because of the fear, we are rejecting it. But if Dr. Nnamdi Eze benefited, Oga Adefarakan benefited, they are the ones that will tell us what are the dangers. Should we go or should we not go? The young ones should not be denied what these older ones benefited from just because of fear. So that's just my advice. This high number of qualified young PTs. Yes, I think that's what we are working on. Issue of the PPP idea, issue of the rehabilitation policy that will bring in budget line, they are all there. Sustainable way is to create more opportunities by creating more departments. I told you, Minister asked me to write, I wrote. I remember UCH was the first to write to us. We are preparing budget. Give us a letter, let's defend. So it's going to take a while. They get their budget and then they begin. Let me leave the profession. Wow, I laughed when someone said that. And I said, please, as you make your money and leave the profession, please think of, no one will tell me they are Ajebo, they don't have any relative in the rural area. So just imagine one of your cousins or the son of your cousin or something like that is living in a rural area with a stroke and they can't walk, not because they can't, but because the services are not there. Boards stand on PPC. I mean, boards does not have the power to approve PPC. Ministry will approve and then board will regulate. So what we have advised the college to do is to write to the ministry. But up till now, I think the first time when they went to see the Minister of State, Dr. Tunji Alausa, he recommended that they go to National Postgraduate Medical College, and they did. The Postgraduate Medical College said they should submit their curriculum. They submitted. And after that, the postgraduate said, you have to review our act before we accommodate you. And that was where the issue stopped, and Dr. Tunji Alausa left. But this current minister said, well, we can work on the PPC that you have. But after 2 meetings that the NSP and the college had, and I'm saying this because I told you I don't want to go into something that is not my mandate. The reason I'm saying it was because they invited me to the meetings. In one, they wrote a petition against me, and in the meeting they discussed PPC I had. In the other one, they invited me not to report me to the ministry, but I went and I had. In fact, the registrar, when the minister asked him, he said, is this college recognized by government? He said no. I think what he meant is ministry has not recognized. I jumped in and I said no. Government has recognized because the PPC is registered with the CAC, and CAC is a government agency. And I told him how we wrote to the Ministry of Education, and NUC, and all of them told us what to do. But the final verdict or update was not sent to the ministry up to the time that I left as president. And I advised them. I said, proceed from that level. Package all those things that NUC told us, Ministry of Education told us, the MRTB told us at that time. Then send it and ask the ministry that based on all these things that they have told us, we want approval for this program to be recognized by the ministry. And then the next thing is to ask them, we want you to give us at least one hospital in each region where the program will be domiciled. So these things have not been done. But if NSP and the college will do that, anything that goes to the ministry, they will write to the board, because there is no rehabilitation division in the ministry at the moment. So they write to the board. And the moment they write, I'm going to give a recommendation that this is the way forward, send it back, they implement, and then after that, we move forward. It will be difficult. It will not be as easy as I'm saying. Some people will block, but there are other things that we have made relationship with people in the ministry. We became politicians. We did what we did, and we can be able to go and talk to people to move forward. But those responsible for the submission need to make that first effort and then push from there. And that's what I've been saying. If we are not having these fights, we would have moved far, 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 far. And all these fights is just about how do you help the association to make money? And I say, let's follow what the act says or regulation. Let's include it in the regulation. And we did that. Called for a committee. The president of NSP was a member. They put in something, and I submitted to the ministry, but it will take long. I say, in the interim, get your members. Let everyone sign, or at least 80% sign. That's what radiographers did. I say, if you do that, especially with the fact that you have increased dues by almost 500%, if you do that, what we'll do is the ministry will say that amount that you have is too high. Reduce it, maybe half or somewhere, if you want us to mandate the board to be collecting dues for you. So if you reduce it, and that's what I will ask, tell government. If you write to the ministry, say we have had a meeting, OGM, and 80% of our members are in support that the board should help us collect dues, then the ministry will send to me. And I am telling you now, if it comes, I will write to the ministry and say that if 80% or more agree for that, I will write and say, okay, I support this, we can do this, but I think the amount is high. I suggest that you recommend that the NSP considers reduction before the ministry gives directive that we should be collecting dues for the association. So that's what we have been discussing. But it's a simple matter. Let's just follow principles. What does the law say? What does the regulation say? And I will help. But just the fact that I was NSP president and now people are expecting I will just use the power of my office and force people to pay dues, I'm not going to do that. And in meetings, I will be told I'm just a secretary. You don't have the power. You must go to minister and get, and then later, when the need comes, they say you have the power, you can. So these are the issues. So, but if we stop all these fights, work on principle, we can discuss all these issues. And sincerely, I must tell you, there is no minister in the Ministry of Health and Education that I will approach with something that they deny. I thank God that I've gotten this favor in this government. And many of the things that are coming out, and the ones that you see coming out, I don't mention things. That's what we did with DPT. We didn't mention what we were doing until it happened. Bam! So someone told me, say, you guys are very clever. If we had known, we'd have blocked it. But it happened, and then they got to know, and it was irreversible. So many of the things that are happening now, you won't hear them. But by the time they click, you just hear them are happening. So I think that's what I have. I'm sorry I took a long time again, but I just can't help it. Thank you so much, everyone.
Thank you so much, Prof. Thank you so much. Yes, you took a lot of time, and it's really needed because we really want to get to the root cause of what the main issue is, why we're having the debates all over on every physical group and all, and because the future of this profession matters to us all, and that is the reason why many of us, we should be on our bed by now, but we are still stuck on this meeting because we want to secure the future of our profession. Once again, thank you so much, Prof. We quite have a number of comments on the group chat that I would like you to give a response to. You can go through them one by one, gather your thoughts together on why I read out some comments from the YouTube link, the YouTube stream, what some of our physiotherapists are saying currently there, their comment, their observation, and their questions. Then I'll call the next 5 persons I listed on the call initially to also ask their questions. I'll continue from the YouTube link right now. Someone says that I work in a village before as a physio. They prefer their traditional healers. The communities are not short of physiotherapists at all. Job no day anywhere. So some of these comments, the registrar might have actually addressed them while he was answering some questions being asked by previous physiotherapists. So if your comments or your question on the YouTube link have been answered, please note it and let's know the ones that have not been addressed. But I would just like to read them so that every other person who is not on the YouTube page can see what other physios do not have the opportunity to join the Zoom link as saying on the YouTube stream. How about the school that just advertised for the training of the community rehabilitation worker? Is the board aware and has the board approved of this? Someone says that MTN, Glo, and Airtel has been available to most rural areas. We can start by posting a physiotherapist per local government whose contact number will be available to all PHCs based on wards within the local governments. This may fly. THCs can have community PHC annexes. There are models already working. Then, why is the plan for a diploma holder to be able to use a shortwave diatemy? Looks like we need to understand where their limit is. I think this was the question being posed to the registrar when he was talking about a particular school that came to the board to request for approval to train diploma holders, and the board made mention of something about if they are ready to train them on how to use equipment like shortwave diatemy and co. If students fail, you can't automatically admit them even with increased quota. Coppers are available yearly, and that is a doable approach. Another person says, good evening, registrar, sir. Thank you so much. You mentioned if majority of physiotherapists don't want these CRIL, CHIL, and diploma stuff, we can fight against it. How do we go about this? So I think the registrar has responded to this particular question, Mr. Jeboda Samuel. You're the one that asked this question. He has responded that we should come together, set up a committee structure. We should bring a proposed plan and find a way to submit it to the available channels that will be provided to us. So you have an answer to your question. Someone said, which rural villages are looking for physios? Please, I and my jobless friends, up to 200 need those jobs. Community should employ us, government should employ us, we will rush there. So registrar physios are saying that they would go to the villages, they will go to the PHC centers in all villages in the rural areas. Physios are ready to go there if they are being employed. Okay. I would like the 5 persons I listed their names to now ask their questions, their comments, their observations, starting with Itiolua Somidotun. You have the floor, followed by PT Afolabi, followed by PT Kalima, followed by PT Nnamdi Ibe, and PT Abdulaziz Arowolo. PT Dotun, you have the floor.
All right, thank you. Thank you, Prof, for the audience. So, my comments on diploma have been said over and over again. So, I want to focus on PPP. So, I did discuss it with some people, and I got to know, I didn't even know the extent of it, but I got to know that things like this already happen in Lagos, even in other states. People approach hospitals, even private hospitals, and they have this arrangement. And the question that I got in that discussion was, what role is MRTB coming to play in a system where this is already happening? Then I wanted to know, I think secondly, the proposal, is it just for government hospitals? And then thirdly, if it is institution, you've already mentioned that the problem is not something, it's not a coverage problem, it's a we want to get people jobs problem. Now that's what I mean, sorry, solution, not a coverage solution. But I think we also need to look long term so that we are not impacting coverage negatively. So, are there any measures so that it won't create barriers for permanent employment in those institutions if we institutionalize this? And lastly, for equipment, I have the understanding that these private physios, these individual physios, would be responsible for providing their equipment. Is there any? I'm guessing that would be very limited. There are only a limited number of things that people would be able to afford on their own. Giving someone an empty room might not really cut it, especially if you want to do certain things. I'm thinking for treadmill, or you're thinking of even stairs and all that, and those people might not, the young physios might not be financially buoyant to cover costs like that. So, is there any financing plan for equipment involved in that proposal? Thank you.
Thank you, PT Dr. Please, if we are coming up to raise our questions, comments, if it's something that has been answered already from what the registrar has said so far, please let's not go over things like that anymore. Let's bring up new questions, new comments, new suggestions. If it's something that the registrar have not addressed, so that we can wrap up quickly. Okay, coming up next, we have PT. You have the floor. PT Afolabi, you have the floor.
All right, thank you very much. Good evening, everyone. Good evening, Prof. Good evening, colleagues. First of all, I must mention that I feel very offended by some terminologies Prof were using, particularly when he said when the stakeholders meeting ended and they thought of an alternative to therapy, and this led us to where we are. I personally feel very offended because if the registrar at that level is representing us with the government, with stakeholders, and is in a position to show them that a reasonable alternative to physio is a diploma degree, I think it's an abuse, is a real blow on us as physiotherapists. It's not a matter of prestige or anything. This is 2026. Dental therapy will not come, or dentistry will not come at this time of the year to say they want to start a diploma program. If you go back in antecedent in history to see when they started the diploma in dentistry, we will know that this has, counted as far back as 50 years ago. So now, if you're not saying because those professions have had existing diploma degree, are we using that as a kind of justification? I personally feel offended with that. So I feel sabotaged by our representatives at the government level, because I will never accept that a diploma is equivalent as an alternative to physiotherapy. That being said, the second thing is that I note from the registrar word that this diploma will not be providing treatments. So what exactly would be their duty? What would they be doing at that community if they are not providing treatments? Are they just identifying medical conditions? Are they signposting the community? To the physiotherapists in the urban area. I recall that as far back as 2018, 2019, myself and PT Alade of Federal Medical Center, we established a community posting of the units whereby therapists are made to rotate to rural areas, employ physiotherapists, including some interns and corpers. At that time, we had people that, it's part of the rotation, you have to go because that's what you're employed for. So what happens to us pushing the established institutions in our countries, like Federal Medical Center, the state hospitals? What happens to us pushing them to establish this subspecialty and make their employers go to these, units to serve the purpose that we want them to serve? Another thing about this heart is this heart already, when was it established? That's the first thing. And is this discussion already concluded? Because I personally note from your Facebook page, I've seen some activities, you posting things on your Facebook page about this actually. And I must remind you, sir, that it is only logical for people to think that you have personal interest in this matter, because we all know that over time you have an institute that you have been, getting on with some training. It's only logical for people to think that the registrar is trying to, push some agenda to make his own institute, flourish in the long term. However, as it goes, we need to be careful about what we portray, because today is what we know. And whatever we do today goes the long way, to speak for us, even when we are no longer available. So to conclude my point, sir, at the government level in terms of implementation, what exactly will be the role of physiotherapists who have graduated without employment? And when we are trying to create competitive markets for this profession, even then, even when we are not even recognized in the country. I mean, how many people reckon with physiotherapists? A lot of them doesn't even reckon with us. That's the truth. It might be hard to hear, but they don't even reckon. And we are like the last resort to, patient problem. So we need to look at this critically. Thank you very much.
Thank you so much, Peter Afolabi. Thank you so much for that swift and fast comment and question. Peter Kalema, okay, you've dropped your hands. Perhaps your question has been answered. Peter Inamdi Ibe, you have the floor. Over to you. Please, if you
I don't understand. Yes, you mean that I waited to ask question?
Oh, sorry. I wasn't seeing your hand raised up anymore. That was why I said you drop your hand. Maybe your question have been answered. Your hand was not raised up anymore. That was why. So if you want to say something, please raise your hand up. Let me know so that I can know how best to arrange it. Peter Kalima, do you still have something to say, or has your questions or comments be addressed?
Yes, please. I have something to say.
Please, can you raise up your hand so that we can know that you want to talk? Signify with a raise of hand. Your hand was raised initially. I wrote your name down, but it wasn't raised anymore. So I thought maybe your concerns have been addressed. Can you still hear me? Maybe our network has gone off again. We don't know. Okay. Peter Inamdi Ibe, over to you. Let's have you.
Okay, thank you very much, Mr. Moderator Elijah. I greet you, our registrar and our registrants, for this opportunity. Let me just go straight to the point. First of all, I think we had this sort of meeting as at last year, and we raised a lot of points and suggestions to registrar. And it does appear as if everything we said was just washed down the drain. I'm not sure why. But then, physio as a profession, I keep saying this, we are still at the evolution stage. We are still developing. Nursing profession, medicine, most of these professions, they were already operating in Nigeria as early as 1948, where 20 years, 30 years before physio came into existence. For instance, typically, the principle of demand and supply, when I was in UNIZIG, the first set of graduates, they were around 20, 30, 40. But now we are having up to 150, 130 and above graduating. And that is because we have more demand for physio. And the area of talking about township or rural area and city, there is no difference between the patients you see in rural area and that of city. They are still the same human beings. So when it comes to the concept of equality or equity of service and fairness, nobody in particular deserves to be seen by a qualified physio, then the others should be seen by akuraku physios, that is the diploma or the support workers. And we cannot say that they are not going to treat people in the villages. They will treat people. We know how these things work. They will treat people. And if you want to establish primary health care, for instance, when I was doing my youth service, I worked in primary health care. I was the pepper there. I was the onion. There was nothing to work with. no single equipment. In fact, that concept of health in our hands, my hands short again. In fact, I had to use I actually overused my hands in the primary healthcare center because there was no equipment to use. I want to bring a suggestion, a concept that can help to drive down physiotherapy down to primary healthcare settings because an average Nigerian does not know anything about physio. If you tell them you're a physio, they'll be laughing at you. Unless you start to tell them that they're a doctor, this and that, and then they can listen to you more. People don't even know about what we do and who we are in the villages. And we are talking about putting our hands in a diploma or community workers. It's not going to help us in any way. It's going to mask the very essence of our existence as physios. And it's going to downgrade our professions. And we know how these things work in Nigeria. So what I see in this whole drive for diploma of physiotherapy is going for cheap labor, getting people that people can pay cheaply, people that have private clinics, and people that have their own personal interest. Because even though we are trying everything possible to make sure that we drive these points down diplomatically, but we can all agree that if all hands are on deck, both registrar, both ACAPEN, both NSP, and we stand our ground that government should increase accreditations for universities that train physios. If, for instance, UNIZIK, OAU, they train physios 200 per year because we need to flood PHC. And government also increase funding for PHC, and they have the ground available, watered, waiting for people to come and work there. It's going to help us to, first of all, drive our message down to the PHCs. Then when we establish our foundation there, and we feel as physios that we need support of PAs, therapy assistants, that is when we can now start making moves. Okay, we have enough physios in the PHC, but they need people that will support them to work there. You cannot put therapy assistants to PHCs to go and work just because you want to survey situations, or maybe someone that cannot, that doesn't have food to eat, but then you present something hard for the person to eat. If you want to lay a foundation, the foundation has to be strong for us to be able to maintain our standards. If you don't do it that way, I keep saying this, people will go back to 2026 and ask themselves, who was registered then? What happened then? And this was when this thing all started and when everything started downgrading. So we need to tell ourselves the truth. We need to stand by the profession. I know you are trying your best, and I appreciate you. In fact, we are the first register that we are having this kind of conversation with for a long time, 4 hours, 5 hours. It's not easy. To be a leader is not easy, and I must give you your flowers. But then you are first a physio, which we understand, and you are first for the interest of all of us here as physios. The registrants will not be happy. More than 10,000 of us, most people are not even employed at all. But if we move the motion of pushing for government to pay people very well, whether you are in the city or in the village, you are a physio. If you go to other country, Australia, UK, if you are a band 5, you are a band 5 everywhere. It's not because you are in the rural area. Wherever you are a physio practicing there. Let's push for government to pay people. If it's Cohen 7, it should be the same for any place you are. You are seeing the patient. Then government should also fund these PHCs so people can have equipment to work with. It's going to help us. Then if you do it for, let's say, 10 years or more, and we are making progress, and if we need support, then we can now start pushing for people that will support us, and not starting to send people to PHCs as support workers or therapy assistants, saying that they will not work. They will work as physicians, or they work as physios. They will carry stethoscope. They will do everything we are doing, even more than us. This is an era of ChatGPT and AI. They will do everything we are doing. They will do even times 2. And they will compete with us in all spheres. Thank you very much.
Thank you so much, Petin and Dibe. Okay, Peter Kalima, you have your hand raised now. You have the floor. Please let's not repeat what has been asked so far. If any comment has been raised and that's what you want to say, let's not repeat it. Let's not go over what has been said so far. If I have answered a question, please let's not go over it. You have the floor, Peter Kalima.
Okay, good evening, everyone. Good evening, sir. My question is this. If rehabilitation workers are trained to identify at the level of empowerment, disability, and maybe activity limitation, since the idea is maybe the BSc physios are more in urban preferable than being in rural area. If they successfully identify and need to refer to physio for treatment, does it mean that the patient is coming over to the urban for management? That's the question number one. Question number two is this. This is Nigeria, and we all know that rules and regulation, ethics are ignored sometimes. So how sure are we that those people too will want to stay in rural and work? Or will the admission strongly based on a particular population? Then the last question is this. Just same way we can't get permanent license without internship, can it be a criteria to working in primary health care before getting the license? Because the Mr. Registrar keep on saying that the younger ones. We too, we were once younger ones, and fight was made to make sure that the profession gets to where it is today. So I'm just pleading with the registrar to please try to review the disadvantage of this to the advantage. Thank you. That's all.
So much, Peter Kalima. That was short and straight to the point. I really love that. Over to you, Peter Asiya Adekunle. After Peter Asiya Adekunle, the registrar would respond to all the questions raised so far and the questions and comments in the chat box that people have been talking about. You have the floor, Peter Asiya Adekunle.
Thank you very much. Can you hear me?
Yes, we can hear you.
Yeah, so I just want to raise a point with the registrar about what he said about his example using the homeless people. And I believe the whole point of this discussion and why we are even talking about diploma and all of that is because of the WHO directive, right? And we all know that WHO is a World Health Organization. And one of the key aspects one of the key things they stand for is respect for human dignity and respect for human rights. If a person doesn't mean if a person is homeless or if a person lives in a rural area or if a person lives in an urban environment, everybody has the right to equal and basic amenities. And I can't say because I'm homeless that I don't deserve to have a PT treat me, then I deserve to have a truth treat me. I can't say because I live in the rural area, then I should be happy with getting crumbs from the dumpster, right? So even if a person is homeless and is getting food from the dustbin, doesn't mean he's happy about it. And part of what we should do as people in authority is to make sure that regardless of wherever anybody is, they have the access to what anyone else should have access to. So if we are doing this because the WHO wants people to get access to everyone to PT, then this will also be a perspective that we look at it that yes, the WHO wants this, but as well the WHO will also want everyone to have access to equal opportunities. So this is one of the reasons why these people, this crew, should not be first. It should not be something that we should even be looking for, because that would actually undermine the whole reason for the WHO. So maybe the first thing we need to do is to get, like many people have said, is to get our PhDs with PTs. I think with the data that we have on ground, it seems we have more than enough people to cover the PhDs in Nigeria, which is 774, I think. So I think we have a number of unemployed physiotherapists right now that can fill that gap. So maybe we start from there, and then if we see that we need more help, then maybe we can start talking of other people, of other positions. But right now, we have enough hands to cover that. So we don't need to start with diploma. I think many people have already talked about this. So I just want to bring that perspective to the registrar that if your reason for doing this is because of the WHO directive, then you getting diploma into the picture is actually going against what the WHO stands for. Thank you.
Okay, thank you so much, Peter Asiya. Registrar, please. I want this last person to ask his or her question so that we can take everything together. I don't know. Techno Pop 20, that is not a name, but whoever that is or who is using Techno Pop 20, you have the floor. That'll be the last person on this particular topic before we have
Okay.
extra.
Thank you very much. Thank you very much. So I just want to reiterate the question I raised in the chat box. So I appreciate the registrar for providing this platform to interact with us, the younger physiotherapists. But I feel that the gap that's still yet to be filled is what exactly is the role of this. I heard someone saying we should ditch physiotherapy and then go for community support workers, community rehabilitation workers. What exactly is their role? And then how does that link with? How does that? I mean, what is their linkage with physiotherapists? Then also the registrar mentioned that all this, apart from the WHO, that the Minister of Health is championing this rehabilitation for all program, and I'm wondering that the organogram for healthcare in Nigeria, the federal government controls tertiary health institutions. The state government controls tertiary, secondary, and then most importantly, primary healthcare institutions. So if we are even talking about approaching governments at all, we should be talking about approaching state governments, not I don't see how the federal government would ensure that what's it called now? That something, and I mean the primary health care that's well, I mean statutorily under the purview of the state government is run properly in terms of rehabilitation and all that. And I'm aware that there are states in Nigeria, especially Oyo State, that are beginning to champion availability of physiotherapy in primary health care centers. So perhaps this is a better approach than what the what's it called now, the registrar has in mind. Well, my most important question is what exactly are the roles of this community support or whatever their name is, and how what is the linkage between them and physiotherapists? Thank you very much.
So much, Mr. I don't know if to call it a Techno Pop 20, but that's the name I can see on your phone here. To take the last set of comments on the YouTube page while the registrar get to answer the last wave of give response to the last wave of comments that everybody have made so far. Physiotherapists and other rehabilitation students can do community postings in PHC just like the nurses and physicians. Coppers doing their service here at PHC and a physiotherapist. The number of doctors to the population is far worse than that of the physiotherapist. Why should we downgrade the profession to satisfy the whims of some people? If there are communities willing to employ, we will go. If a large number of physios are jobless, why do we need diploma? Technicians won't get jobs. Same way occupational therapist technicians are now nail techs and braided. Let's just be deceiving ourselves. Let me just see money first. Another comment here states that let's start by having mandate to employ physios to PHC first. And see the way forward from there. Oyo State is already doing this, employing physio in the PHC from what I've heard. I think the core impact where rehabilitation is concerned in most rural community is TBS, not CHIL. How many of the population needs curative services and how many are getting these services? Is the 20 institutions asked to start a physiotherapy program or other rehabilitation professionals under MLTBA? I would like, oh, we have one more person. Okay. Registrar, please, again, let's just take 2 persons. I'm sorry, I may have to call you guys after Registrar has addressed the ones that we have quite have a lot. Or Registrar, do you want me to take the remaining 2 persons before you address them at a stretch?
Whatever you do is fine with me.
Prof, sir.
Yes, I said whatever you do is fine with me. It's okay, whichever way.
Okay, right. Let's take the 2 persons so that I want us to be done with this particular aspect and move to the next one. Okay, PT Olawale Oladimeji, you have the floor. After you, PT Odinaka, you are going to take the floor. Let's make it short, precise, straight to the point. You have the floor, PT Olawale.
All right, thank you very much, Neolua. Good evening, everyone. Good evening, the registrar. First, I want to appreciate you for your time and for coming here to actually discuss with us. And then I'm not going to repeat what others have said. I'm just going to add very briefly 2 things. I'm glad you mentioned the fact that we still have issues with regulation in Nigeria. And we all know the way the system is in our country, where we have quackery everywhere, even in the medical practice. And there's even more in physiotherapy. By virtue of my voluntary experience, I have seen a lot. I go to villages at least twice a year to volunteer with organizations, and then I see so many cases. In fact, more than 70% of cases that I report are those with new musculoskeletal issues. And then I've heard stories that people in villages, in fact, the chief that we're talking about, they go as far as prescribing, far as setting lines for patients, in these guys as physicians. So in my own honest opinion, and based on what you also said, I think the issue of diploma in whatever guys, either community health extension worker, therapy technician, will not do this profession any benefits in the long term. I wouldn't want to go into stories because a lot has actually been said. But sir, I want to plead with you to reconsider this in the interest of the future of this profession. The younger ones are saying that the board needs to reconsider this. We should push a stronger argument to the government. We have a number of physiotherapists that are unemployed, a number of them. And then the tertiary health system, secondary and tertiary health system are even beginning to be overstretched. Why? Because there are no physiotherapists or there are no people in the primary health care level. And then one of the ways by which the government can even incentivize people or physiotherapists to work there is by, many people have said this, have a salary structure that is at par with those in secondary and tertiary. And in some cases, or in most cases, even have rural allowance. I know this used to be the case in the past. I don't know if it's still in existence. We have rural allowance. You have those working in rural areas even earn more. And this will motivate people to even work in rural areas. So my point in simple term is that, sir, in my own honest opinion and based on what people have said, and from my own little experience, I think in the long term, diploma in whatever guys might not do this profession good in the long term. That's number one. Number two, in terms of regulation, sir, I have seen a lot. So many quacks everywhere. In fact, I've met some of them, and it's just it's a mess. It's a total mess. And then I'm aware that there is a surveillance group or a surveillance committee, and I think they're not doing enough, if they're doing anything at all. And I think the board should please look into this. It's beginning to become a shame that you have to compete or you have to begin to explain yourself that I'm a physiotherapist, and they tell you that this other person brought in fire to see a patient in the ICU and all of those things. So it's beginning to become a mess. And I want the board to please step up in the area of surveillance, in the area of regulation, and make scapegoat out of these people. They are beginning to give us bad news out there. Thank you very much, sir.
Thank you so much, Peter Lawali. Peter Dinakas, you can go to the tip of the mic and speak now. Peter Dinaka, you have the floor. If you can hear me, Peter Dinaka, you have the floor. We are waiting for you.
Okay. Good evening, everyone.
Good evening, sir. We can hear you clear and loud.
Good evening, my registrar. Okay, I have a pressing issue concerning this. With my little experience, I've had in course of practice. I'll just say it how it is. I came to realize that in physiotherapy, we already have technicians in existence. I don't know how, like, right from the time I was in school to when I graduated, I've never seen anything like that until I was posted to military hospital. So I came to realize that this our profession has physiotherapy technician existing, and we never knew about it. Now, and I've worked with these people, in fact, to the point that they make their HODs that are physio technicians. They make their HODs that are physio technicians. They make them HODs. People that just were trained for two years, they will just become HOD. Meanwhile, maybe someone that was recruited through MOD cannot be HOD. So I've actually had experience with them, and I've seen the harm it is really causing. Most times you can't even tell them to do anything because they also form that they are also physiotherapists. You see yourself fighting with them, just trying to maintain the professional ethics and all that. So there is always a breach, and it causes so many issues. So I feel that at this point, we have not attained to that height of embracing diploma in the profession, especially in Nigeria, because in every aspect, we are lacking standard. And I'm very sure Mr. Registrar, I'm very sure that was the time I spoke to you about this. And that thing really affected even the salary structure of the military hospitals because of the existing technician. They always say that, since these people are existing and they're doing the work, why should I pay you so amount if they can? So the thing brought in that sense of them having cheap labor and then paying physiotherapists, not even valuing their physiotherapists. But other departments like radiology departments, medicine and surgery departments, dental departments, they have a hierarchy system. They respect their professionals that come in. But it's only physiotherapists that they don't really respect, they don't value. So I feel that we embracing diploma now is actually going to affect us in the long run, especially in our country that we know that so many things are going wrong right now. Now, there is this common TikToker, Dr. Tedola. I used to follow his page and I used to have some discussion with him as well. So most times he talks against CHOOS, the existence of CHOOS, like the challenges they are causing to the medical practice. And these CHOOS, they will even come openly challenging him that they do what they can actually do what the doctors do. They can do surgery. What do the doctors do that they cannot do? So if like these are people, this medicine is actually a profession that actually gained so much ground, but yet they are still having the heat. Talk more of physiotherapy that just started 1970 something. and you feel that you could just introduce diploma technicians everywhere and feel that we could still have the same value we have in the country, it's never going to work so far as I'm concerned. And if we really care for this profession, it's actually, we don't need to embrace this. In fact, I would even prefer, some persons would prefer to be doing the 2 years or 18 years program diploma course just to become a physiotherapy and do what physiotherapists do. Reason being that since if they could graduate from school, pass through school, and there is no much benefits, why would they now pass through those rigorous stress and the rest? At the end of the day, you are undervalued and all that. So I feel, Mr. Registrar, if there is a whole lot to be done in this, so if you can even clear me on that, on this note of having technicians existing in the military and not having enough regulatory regulations going on there, it's actually very appalling. And military hospitals are meant to be taking interns. And from my records, the interns they take, I don't think they pay them. The last intern they took, that was, I don't know currently now, but as of 2023, 2022, 2023, 2024, what they paid them was not even up to 150, it was 120. Then the military in Port Harcourt here, they don't even take interns at all. Military hospital, and we have just 6 or 7 of them in the in the government. So why would all this, if we actually, the board are actually fighting or regulating these people, I believe that they could also be taking in interns, but they don't even have the equipment, they don't even have the staffs to actually train interns. The few that does, they don't even train them very well. Everybody could attest to this. So please, I don't know how we could regulate these technicians existing in the military, not only military, Air Force, plenty of them. So I don't even understand how these things work. Thank you. I think I've spoken a lot.
Thank you so much, PT Odinaka. Registrar, you have the floor to address every concern, every question that have been raised so far, including the one on the chat box that were addressed to you too. So you have the floor, sir.
Okay. Thank you very much. Thanks a lot to all that have also added a lot to what has been discussed. I can see that there are some cases that are similar, the same with what I've responded to. But then I understand either people want to lay emphasis on it still, or possibly they came in later. But whichever way, I'm not going to dwell on things for long because of time. I'm going to address the issues possibly in a summary based on those explanations I've given earlier. Secondly, I want to emphasize, and I think I've said this several times, that there is none of what is happening that is the registrar's idea. That's none. What I stand by very strongly, and I've told people, and I've said it here and in many other fora, is that citizens of this country, especially those that are most vulnerable in rural areas, they need the services. And this is something that was a unanimous resolution during the 2023 November stakeholders meeting that we all agreed at that meeting. Resolutions were made. So it's not so. How to do that at the community level? I've told you, I got recommendations from people. We set up committees. Committees had discussions, made recommendations. We went to the authorities. They selected what they would accept to do, and that was what we have been working on. So there's nothing that is the idea of RUFAI. The idea of RUFAI is just that resolution that rural areas should have services. I agree with that, and I stand by that strongly. But how it's done have all come through suggestions and recommendations and committee works and stakeholders meetings. The same thing with the issue of technician, because these are two different things. The technician thing is in the act. That one is not in the act. The technician thing, that one is not in the regulation, because the act just says diploma, and therefore it can cover all. So, but the issue of physiotherapy technician is in the regulation, following what the act says about diploma generally specified it. And this is what we have been discussing. If you want it to go, review and change. And I think we have discussed how to do that and all that. So I'm not going to go back to that. The issue of preference to bond setters, I think this and all other issues that have come about CHOOS, whether they are doing well in the communities or they are not doing well, I think I've mentioned it. And have people do an analysis of the impact or not that the CHOOS have. It will help to be able to know whether, if advising government on this particular matter, whether that can be used as a reference. That see, they are making things worse there. If you weigh, having them is worse than not having them. So that analysis is important. And I'm not going to say anything about it because let people do that assessment so that we can be able to compare notes. Then the publication of training of community rehab workers, we are not aware formally. I saw that this evening while I was traveling. And as I've said, many of these things, you just see them on social media. The veracity of the information you don't. But whenever we see them, we pick them up, try to verify. But this has not come to our notice formally. We are not aware of it, and we are not going to regulate. And if you look at it, I saw it. All others say ND, 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 ND. But it is only that particular one that didn't say ND, just a community rehab or something like that. Yes, so posting pitches to local governments. I mean, I went to Oyo. I led a team from the Ministry of Health and MRT to Oyo. We presented the Rehab 2030 initiative to them. The commissioner invited all the executive secretaries under the ministry and all the directors. And when we finished, she asked for the documents that help clarify on issues of rehabilitation in primary healthcare. And I sent it to them. And just a few weeks after that, they employed the 32 that we have been talking about. So it's not that employment of physiotherapists at the primary healthcare is not being done. It's done. It's because this is an example, and it is through this movement that we were able to get that. Yes, so that has been done, and I agree that it should continue. But whether it will be enough to cover the needs is something that we can analyze. Learning how to use infrared by diploma. See, there are two categories, and each has its own jurisdiction. I'll give you an example. Nursing, they have community nurses, and community nurses in their training and their scheme of service and the laws, regulations of nursing council, they cannot work in a secondary and tertiary levels. They must work at the community level only. So I heard of a hospital. I was there recently, and I was told that some politicians brought in those with community nursing to the hospital. And the nurses said, no, the regulation, this is what it says, they can't work here. But because of the influence, they were taken, but the hospital now decided, let's send them to study something that would be relevant in the hospital. And they had to go back to school, study something relevant in the hospital, and then they came back. So there is jurisdiction. Community nurse can only work in the community. But a nurse or midwife, RN, they work in the hospitals, submitting to someone that's a nurse that has a degree, and that is how the structure is. So if at the end, whatever is chosen, if the power doesn't go through, then this issue, not even a problem. But if by any chance it goes through, then it is about having those jurisdictions. Where can this person work? Where is it that that person cannot be able to work? So those that are going to work at the community level, are proposed to work at the community level, they are not taught infrared. And that's why I said some people maybe joined us at a later time. Because I mentioned this, that when someone recommended community rehab and the first committee put in some things, not even infrared, just physiotherapy, someone came and said, expunge it. Just put in things that are general about identifying the problems, health education, referral mechanisms, and all that. And that is what is in the proposed document. How do we go about stopping diploma? I think I've explained this. Let people put in justification, but not one that government will pick holes in. Then I said I'm going to ask for a meeting with ministry officials, the representatives of the profession, and then let all the proposals and the positions be presented. And let's see what will happen after that. Community to employ, I've mentioned this just like Oyo has done. What is the role that MRTB will play on PPP? See, there are many hospitals, especially secondary hospitals that are in states. For over 60 years of our existence, they have never employed any. And I gave you an example of how I went to Nguru, just from service, people at the hospital established a department. So the role of MRTB is just listening to all the yearnings of the young ones. We said, okay, let's be like liaison between the young ones. Like I said on Tuesday, I will be at the meeting of committee of CMDs. It's just to liaise. I was with the minister. I was with ICRC. I was with PPP. So it's not all the young ones that each one will just go and see all these people. So it's just a liaison. If there's interest in it. If there is no interest in it, let me stop even going anywhere. Because as I've said earlier, you look at percentage that say majority don't want it, you stop it because it only relates to you. And since this PPP, as I've said, the primary purpose, at least for me as an idea coming up, is not provision of services, help the young ones. So if we don't want it, let's just drop it so that we don't even continue to engage on that. There are measures not to impact negatively. I think these are things that we need to begin to look at. I mentioned the issue of assessing what CHUs are doing out there. How we do PPP with, I mean, someone is saying if you don't have any equipment, I told you, we have gotten some funds promised by an organization, a foundation, and we can just the board. Other people can also reach out. But even if you don't have anything, that's how I started. I didn't have a single equipment. I went to the ward, I saw patients, and they were paying. Later, I bought the equipment, and the people were paying. And that's how we will continue to grow if there's an interest in doing it. Sorry to the person that said he was offended by my terminologies. I can't remember what terminology I used that was offensive, but what I understood from what the person says was that issues of diploma in dentistry has been on for long. Why am I saying that now physiotherapy should be done? And I've cleared this earlier. I said I've never said anything should be done. The act is the one that says it should be done. And I said I will not encourage anyone. But if people approach me, I can't say no. Because if I say no, let's assume they go to court. The court will say, well, your act says you should do it, but you're saying you are not doing it. So what's the basis for that? I've said it. I agree it's important because it is going to add to the workforce. But I also understand the problem it will create. And I said, let's work towards reducing the impact of the problem before it now becomes at the end that it must be done. Maybe someone will force it on us, at least we are prepared. But I will not encourage anyone to do it. But if they come, that's what I said. So, but I don't know what's offensive. If there is anything that's offensive, I'm very sorry. Duty of diploma, if they are not treating, I think I've mentioned that they identify referral mechanism, health education, and then other things. The proposal is there. Maybe we'll discuss it and share what's in the proposal for the curriculum when we meet in the stakeholders meeting that we're going to have soon. Someone asked ACT, when was it established? 1988 as a decree. And in 2004, it was converted into an act of parliament. My institute, I laughed at that. Believe me, if I want to make money, I'm not going to become registrar, suffer for 4 years, fight with my colleagues, get insulted, abused, just so that I will establish a program of diploma in Nigeria, and then I will go back to my institute and do it and get how much? Sincerely, it's sincerely to me. I don't know, but whatever it is, if there is an evidence to that, present it. When NSP reported to the minister and said he's having institute, and I said, we'll do. I told the minister, and I will tell you, the president of this country, ministers, governors, almost everyone has a company. And they are the ones that appoint IRS bosses that will go to those companies and collect, what is it called? And no politician has ever said they should close those businesses. Yes, but when they did that, I told the minister, I said, I have every right to run it. It's only if there is any wrongdoing, evidence of wrongdoing, that I can be penalized. But I said, in the interest of peace, so that I won't be distracted, I will step it down. And I did. When the people that were running it decided They are not going to stop it. They want to establish their own. They went and they registered with their own name. I am not involved at all. I'm not involved. My name is not there. I don't get anything. They are running what they are running. They are continuing. And I stopped it. And it was bringing something to me. My salary is 804,000. What I'm getting as lecturer, or what a lecturer is getting, is much more than what I'm getting. I've never gone on accreditation. And that is why people get DTA. Sometimes I take tricycle to go to places. So, I mean, what's the benefit? That I will come here and suffer just so that I can go and establish diploma to get what? When DPT was approved, I was inside Villa. I went for an assignment. Some people know what I went there to do. The day I finished my assignment, I didn't tell anyone I was leaving. God is my witness, I never collected anything. If it's money that I want to establish business, I will not go into a diploma business. I will go and oil business and get more. So role of PTs without employment. I think I've discussed a lot of how rehabilitation policy can include budget lines, and we are following on that. And I hope and believe that we are going to have something that will come out of it. Let me pick another one that is new that I have not had. The issue of WHO direction us to do this. WHO does not direct any country to do anything. They just come up with their proposals. And then countries sign in to say that I agree, I'm going to do it. The country that said they don't want to do it, they will not do it. So WHO did not direct. I told you, we had a stakeholders meeting. We presented the WHO recommendations. And Nigerians, the stakeholders, the two presidents of our associations, they were there. The stakeholders were there. And we all agreed that we should do this thing. How do we do it? It was not presented. Let me also apologize if I was being insensitive that I talked about the homeless person. I was just trying to give an example. But I agree that they should get shawarma just like every other person. But I explained. I said, if they can't get it, should they die? Or should they take something that will help them to survive? If they have a problem, it's a reversible problem. And then they get, but let's go and find out. Is chew killing people out there? If it is, then advise government not to do it, even though there is no alternative. How many physiotherapists go to those rural areas that you have to keep your car and cross a river to go and treat patients? We don't give them. So why are we denying them the one that is not up to the level of a DPT? That's all I said. That's all I meant. But if it comes out as insensitive, I'm sorry. I agree with the policy that dignity, right, I agree with all that. But if government has not given them, should they just die? In Sudan, in Gaza, go and see the way they have become emaciated. That right is there. WHO is still in this world. But go and see what they are eating. Sometimes 3 days, they will not eat anything. And whatever they get, they eat. And that's how people, organizations keep going in to try to help them with the little they can give them and go to a very remote village. The food they eat, sometimes if they give you, you will take one spoon and then you just leave it because you can't be able to eat. But they are eating. What's happening to them? They are surviving because it's about survival. If you have money, you eat shawarma. If you don't have, you have to just get something and eat so that you can survive. That's what I said. But if it comes out as insensitive, apologies. I'm very sorry. There are other things. I'm just trying to pick things that I have not mentioned earlier. Step up area of surveillance. I've mentioned that. I agree. We are not doing well, but we have started putting in things in place that will help us to be able to do this. Please reconsider this. I've said it earlier. This is not my idea. We all agreed. I got recommendations. We started what was recommended. And now we are going to give everyone the opportunity to come up with something that is a better alternative or stopping it completely. I will convene a meeting with the ministry's officials and professionals, present it. Let's see what's going to happen after that. If the meeting says no, ministry agrees, remove it from the act. What's the problem? No problem at all. I don't have any problem. As I've said, I just feel that if I'm responsible for something, let me not ignore that responsibility. And the responsibility I have is for both physiotherapists and those poor people that are in the communities. And you can bear me witness. I don't have to say it myself. I have labored to support physiotherapy from the time I was president until now. And I told you, there are things I can't tell you that I'm doing for physiotherapists because I don't want people to come and stop it before it gets to the point that it's approved. So I think these are some of the things that I've seen. If there's any that you think is important, I've not responded to earlier, I just call my attention to it. Thank you so much. I appreciate all of you. Let me apologize to anyone. From my statements earlier before this meeting to anything I've said in this meeting, I'm a human being. I said earlier, I can be very passionate, and that passion can move you to get off the road. Listen to people, they can bring you. Last thing that I will tell you, when I finished my PhD in the UK, Southampton, the first thing I did when I came back, went to two people, elders in Kano Teaching Hospital, Malam Garba, Malam Musa. And I said, I've come back, my head is warm. I'm going to step on toes, trying to establish what I've seen in the UK and in the other places. And I said, if I step on toes, please call me to order. And from that time until now, whatever I do, like this, if I'm called, say, look, you have to change your approach. I always listen, change. It doesn't matter if it is young people. You can tell me and I will listen. If I'm wrong, I will apologize to you and I will move forward with life. So thank you so much, everyone. I appreciate your apologies once more.
Sorry, you haven't addressed the technicians' existence in the armed forces.
I think I've mentioned this. I mentioned this, and I said that when registrar was posting things about those issues. We don't have people at the professional level in the military. I'm as registrar, I discuss with those in the military. Just like you said, there are departments that deployment head, or they are the ones in charge seeing patients in the military. Is that a good thing? I mean, we're still afraid of it. But why was it approved? I know why it was approved. Because it's in the law. If you can intimidate a businessman that is establishing School of Health Technology, you cannot intimidate the military. And that is why the registrars approved it and they allowed it to go. So now we have come to a situation that ministries say, this is our policy. We want to produce more workforce. I even resisted, and I've challenged anyone here, go around the whole country and tell me one diploma program that has been established, accredited fully, running, producing diploma as a result of what Rufai did. I resisted it. I said we need to establish ABC. They give me the chance to move and try to do the establishment. Wrote letters, start this department, employ more, accreditation, you must do this, you must do that. That's what I've been working on. The reason I've been telling people, let's change our mindset about the issue of diploma is because I see the future that it might come to us, we are not ready. And as I've said earlier, what are we doing to address all these things? We have meetings, we list things. Tell me, what have we done to address them? In 60 years, we have done a lot. Our elders have done a lot. We have reached a very higher level than we were. But we are still comparing ourselves. The question you said, people respect other professions, they don't respect us. Why? If you squat, someone is standing, they don't have any I don't know, this example also might look like it's offensive. Let me not get there. But I feel personally myself, I've not developed myself in the area of clinical practice that I want to really see myself that level. I've not. So if I don't and I squat and someone is standing, he has no option than to look down. But if I stand, he has no option than to look at me in the eyes. Because if he look down, then he's shy. So that's the issue. That's the way I see it from my own view myself. I'm sorry, I'm not saying any other person so that it will not look offensive, but there are a lot of things. I can't just exhaust all of them now, but apologies to everyone if I've...
Thank you so much, Prof. Thank you so much. We really appreciate everything you've said so far. I want to believe that we are making the headway. So many things are coming into the light. A whole lot of early parameters and getting more understanding on what is at stake and why some things have been the way it was in the last couple of weeks. We want to move to the next. We have two more agenda before we end with 15, but I can see someone and raised P.T. Adebambade Farakon. Is it still on this current topic that you want to, that your hand is being raised or is raised for, or something else? Because we want to move to the new agenda. Or is it your hand that was raised initially? P.T. Adebambade Farakon, your hand is raised. Can I know Is it the initial one or?
Yeah,
different?
thank you very much. Thank you very much. I just want to throw light on the issue of PPP. You understand, because I practiced PPP for close to 13 years. And I think, I have huge experience when it comes to PPP. Then the issue of the military, diploma training. Let me start from PPP. Can I go ahead? Do I have a floor to just make a clarification on PPP?
Okay, you can go ahead, but keep it
Thank
very
you.
short and precise.
Okay, thank you. Thank you very much. I started PPP long time ago, from 2006 with CBN. And what I did is that I identified that I was going about, do PPP in one hospital. It was in that hospital I managed a patient, CBN patient, that told me that there's no patient and there's no physiotherapy in CBN. And I put up a paper, I approached them. We had, an MOU, and they don't have any equipment. So what we agreed was that they'll give me a space, I will keep it, and I will be seeing only their patient. So we came, we signed a MOU, we signed oath of secrecy, and, that is how I started. And when I started, of course, I employ, because it's just like I'm running my clinic, I employ physiotherapists working with me from 8 a.m. to 8 p.m. And we're doing well until when, one of my lawyer's staff, I felt that, the best thing I could do for them is to get them, permanent in CBN. And I wrote a paper, I make a presentation to the board. And fortunately, the Emir of Kano was my very good client and, friend. And we spoke, and they said, okay, if they are going to establish PPP in that place, if they are going to buy their equipment to start a full unit there, that I'm going to head it. And, I talked to them that I have a able hand. That is today, we'll be able to establish, physiotherapy units in CBN. And they asked me to do exam for them. And out of 6 people there today, 5 of them are my products from my private clinic. You understand? So that one aside, that is a good news if you want to take that. Then the other one, yes, registrar cited an example of Nandi. And I know Nandi is here. Nandi is my very junior colleagues, and, and I think he learned a lot from me. And when he joined the hospital, one of the problems Nandi encountered was that he's there, he should be able to tell us, was that he came to me and tell me that, look, this doctor, they don't like to pay physiotherapists. Once they know, they have a patient, when it's time for them to pay, they start telling stories. No respect for physiotherapists. And it was out of that frustration, I think Nnamdi left that hospital. But being a very good entrepreneur and whatever, never look back, you understand. It started small. Now it's big. That is the problem with PPP. When you are doing it with government establishment, of course you have MOU. But when you are doing it with a private hospital, I had with another private hospital, whenever I get there, they will ask a nurse to come and stay with me. I thought they were protecting their patients until suddenly they didn't call me when they have a patient again. Then I stumbled into one of their clients, and the guy called me, doctor, what? I said, no, I'm a physiotherapist. He said that I've been coming, we don't see you there. I said, you have been coming. They didn't call me. He said, yes, it's your colleagues. That physiotherapy, your colleague that stay with you, that is now managing them. What that means is that, of course, they stationed that guy to learn the heart, to see what I was doing. And they felt that, oh, they cannot be paying me 50-50 for the patient we see. It's better they go for this. If we are, the board is trying to promote PPP, which in many ways, they don't even have, anything, because it's between physiotherapy and the hospital. Is a private business. So it's not between your agreement. So if we are trying, say we want to establish PPP, and we now want to roll out a diploma, I can assure you, instead of even calling a physiotherapy and asking a nurse to come and spy on you, they will not. They will abandon physiotherapy and take, diploma. So we have to be very careful that we want to achieve something, and our approach on the other area is counterproductive to that one. That is number one. Then on the issue of military, I remember vividly the military training has been there right from the time of Mr. Jogunwola, Dr. Jogunwola. And I knew the efforts, because there was a program we did in Abuja that I have to engage the former registrar. I knew the efforts that she said she has tried. When they stopped, the last diploma they stopped was in Kano, when they have to tell the university to, accommodate them to start BSc physiotherapist. And according to her, that she had made the same approach to the military. And the military said, well, we are different to the public. Yes, you are the regulator, but this diploma we are training, the hospital as the physiotherapy assistant, they are only limited to the military hospitals. That the reason why they needed them is because, they have engagements. Maybe they go to war, they need a physiotherapy, and they don't have enough. And that was how many years ago, when we don't have enough physiotherapists. And according to her, when she released the last, because she may not be here to defend herself, when she released the last, what she wrote about her activity, about her tenure, and the issue of DPT, you understand, was that he now had MOU with the military that, okay, we will allow you to operate from this time to this time. That immediately they now start University of the military started their university. She approached them and told them that now that you have a university, it's better you consider bachelor, not even BSc, bachelor in physiotherapy. And I think that was
to wrap it up, sir.
And that was the reason why, she went to disregister to stop them from further, a year before the register came in. So those are the two things I want to talk. Then finally, I just want to appeal to the registrar. You are a registrar because you are a physiotherapist. You are there for our interest. Though the government interest also come, but you are majorly there because of our interest. And if you have heard all the submission today, 100% said no to physiotherapy. And I don't believe if there's already an act, we won't be talking of this. Act is a final whatever. So the act is still, being fashioned out. So we will appeal to you, please tell the minister, go there, tell them that, no, the people I represent, this is what they say. This is their stand. And the other thing, we have the thing people have signed, the petition people have signed. We can, after the whole thing, we will write to you to look at the petition. Not that you are not, we just want to carry people along. You look at the petition, then you can present it. If we now present the petition and the minister or the ministry, they are adamant, they cannot tell us how to run our district, we will do the needful. So please, I just want to thank you for this opportunity. Thank you very much.
Thank you so much, P.T. Adebamboade, for so much. I'm very sure the registrar have taken note of that. To do justice to that also, sir. Before we end the meeting, we have 2 quick agenda to walk through. Registrar, sir, we want to raise concerns over licensure issues and letters of good standing. What is the latest update as to how our license would be go through a faster process? We understand that you said something about the website being getting ready, being perfected, and will be launched fully in the coming months. But before that time, sir, we see quite a number of registrants who have complaints concerning license. People applied for 2 years but were given 1 year. People who have been trying to send messages and mail to the NRTP mail using the previous format of renewing licenses and all. And what is the board doing as regards how some of these things can be addressed? So far, so good. We have the first, sir. Also, sir, because this is a meeting for any career also, for interns that are just graduating and will be migrating to the full license from NLTB, majority of them have been having issues of how there are some interns that they do not go with a certain batch and they need to get their blog books and everything up down to the NLTB office in Abuja. The cost of sending their logbooks, everything and all physically to where it's supposed to get to, it's really draining on this set of interns that at the point of way that they do not even get to receive salaries anymore. And is there a way that all these documents, all these things can be done online, uploaded, scanned, and sent instead of having to send through will bill, money, and all those things? Please, I would like you to respond to this, sir.
Okay. So number one, the issue of 1 year and 2 years license. If you miss any of the requirements for 2 years, automatically the board gives you 1 year. That's if you're applying through email. Because for the portal, it doesn't give option when you apply for 2 years that you are given 1 year. Therefore, if it's in the portal, it will be rejected so that you have to make another application, either with all the requirements or you apply for 1 year. So that's one of the reasons that people get 1 year instead of 2 years is CPD. So the CPD has the domains. So if you don't have any of the domains, or possibly the CPD is not one that's recognized, I mean, there are a number of reasons. I won't go into the details now because of the time. But if you don't have full requirements, get 1 year, even if you apply for 2 years. Now, the portal would have said everyone must apply through the portal. I know people that have applied through the portal, they have said it's smooth because you just go there, you apply, and at the end of the day, just 24 hours, you can get your license. So it's smooth, but we said people may not be familiar with the technology. So let's allow the email to run with the portal until the end of the year. So that by 1st January next year, then everyone that applies through the email will just send them a reply with the link and say they should go to the portal. Another reason why we didn't insist everyone must do it through the portal, because we never had digitalized record in the board. So all our files were hard copies. So we had to convert them into digital format and upload on the portal. And since it's the first time that we were doing that, there were errors, and it wasn't all that were uploaded. And therefore, we thought if someone checks and their record has not been uploaded, they still have an option to go through the portal. But we have had people checked the records. We have also asked people to check if there are errors or they are not there to send to us. There are people that their job day in, day out is to make corrections and upload more. And we believe by the end of the year, all that will be completed, and then we'll transit fully to the portal by end of the year. There's also something that we have done now. What takes time, makes us to have a delay, is the issue of CPD being checked. Now we have a portal for CPD. It has been developed, it's finished. So if you go onto the portal and apply, or if you do your CPD and you go onto the portal and register with your certificates, they have been approved. We are going to link that CPD portal to the license portal, so that the moment you make payment, you are going to see options of the CPDs that you have done, just to click select. The moment you select, you submit, automatically within seconds, your license will come to you. Because that portal that we have cleared that your license is acceptable will be linked to the registration portal, and therefore someone doesn't have to go and be screening. The system itself will do the screening automatically, and you get your license within seconds of applying. So all these are in place by 1st January next year. Everything will start to work. The issue of logbook, we have already digitalized logbook. So for those going for NYSC now, like tomorrow, internship, like tomorrow, after the induction, we'll give them a soft copy of the PDF that you can write in it, so that when you go for your internship, you'll be filling in the logbook online. When you finish, take it to your supervisors or whoever it is that will sign. If they can't put their soft copy of signature for whatever reason, they can print, give it to them, they sign, you scan, and you attach the scanned copy to the other format, and you send it to us through email. And with the internship portal that we have developed also, you don't even need to send email, because before you start internship, you register, and after registering, when you finish, just go to the portal and you submit your documents, and it comes to us through the back end and we'll process. But for these ones that you're talking about, they have very short time. I can just give you that approach, just go ahead, scan. But because you are not the set that we are facing out hard copy with, if you send the soft copy, you will still have to send the hard copy, so that there won't be confusion in the board. So you will send the soft copy, we'll use it to process your license, but then you will have to send the hard copy so that we keep the record. In the case in the future, we are saying from what year have we phased out, we know we have the record of the hard copies. We are not talking about that year. So these are just a few things that I can say about this. Thank you.
Okay, thank you so much, sir. Thank you so much. Do we have anybody who wants to make any comments, ask any further questions as regards the current subjects of discourse at the moment? Any students on the call, if you have any clarification concerning anything, it's time for you to raise your hands and ask your questions, raise your comments. We are on any other business on the agenda right now. If you have any other thing you want to say generally, you have the floor now. Okay, Prof, somebody asked a question on YouTube. So there's this particular case of someone who was told to keep paying for CPD. He is an intern. He was told to pay for CPD in the hospital, compulsory 5K every month for CPD, knowing fully well that they were explained to that corpers do not need CPD points to renew license for them to get a permanent license. But this person, because he is an intern in that particular hospital, all the interns were forced to pay a 5,000 naira amount of money for CPD every month. So the person is asking a question that is this supposed to be so, and why should this be allowed to continue, sir? We have the
Well,
floor, sir.
Yes, thank you. I think initially I mentioned that the principle that if there is a policy in the hospital and you get in and the policy is there, then it's up to you to say, oh, I will follow what the policy is about and stay with them. But no, I don't want to be there. I'll go to where they don't have that policy. But I know that in the board, we don't ask for CPD when you finish your internship to register. Because I think the CPD, the training of the internship is a training and it's a CPD on its own. And that is why we don't ask, at least for now. We don't have any reason, I think, to ask interns when they are registering to submit CPD. For those that have registered, we don't ask. And therefore, if we are not asking for it, then the people that are in that hospital are expected to teach you because they are being paid teaching allowance to teach you. I don't see any reason why there should be a policy in a hospital to say you should pay 5,000 for CPD when the internship itself is a CPD from the board's perspective. And of course, I can think like that. So if you do your investigations and you realize that it is not a hospital policy and that in the hospital, departments don't have the power to come up with such policies, you can write to us so that we can write to the department. If you want it to be, we can try to cover and not let them know who sent it. We can even say that one of our surveillance volunteers came and they found out this is happening. Can you please explain? Because you are our registrant. If you come up with something that's against principle, we can query you. So if you can't explain and you don't stop, you can always write to the management, say that as a board, we regulate internship, and this is what we have found out, and we are seeking for clarification. Is this a policy? Because interns are complaining, and we just want to make sure that their internship is going according to principles that have been set. And that's one of the reasons why we came up with this regulation for internship. The moment it's approved, it's going to help us. And these issues, look at it. If they are not there, we can include so that it covers things that can help us to be able to help at the intern.
Okay, thank you so much, sir. Thank you, Prof. Piti Odinaka, you have your hands raised. You have the floor.
Okay, sir. It's a quick one. I got a report from my junior colleague. She's currently doing an internship in Aso Rock Clinic. So I got a report that so many persons, after doing their internship, full 1 year internship, they're not being paid. And I'm asking, why are they doing internship in a place that is accredited, but they're not paying the physiotherapists, the intern physios? Like, she has even done 5 months straight without pay. And they actually made them to sign that they will do internship and not be paid. So things like this should be addressed. If they should take interns, they should pay. And because of they're leveraging on the fact that, okay, these students just graduated, they don't have option, and they don't want to stay at home for 3 years, 2 years, 4 years. So they just have to do it and let go. I feel that the board should come up and do something about this, because Aso Rock Clinic is really a very big institution. Them saying that, and why is it just physiotherapists that are not being paid? Thank you, sir.
Okay, thank you very much. Now, let me say this. The start of this meeting till now, and I know this is a meeting with the registrar, but in many meetings, you get a request like this, that let board do this, let do that, let board. There's a lot, and we try to see. I remember when the Otun's team came, I told them, I said, look, this is responsibility of the ministry at this point in time to create to get central posting, to do this, to do that about interns. And I said, okay, let's go to the ministry because it's their responsibility. The Boards Act does not mandate to do ABC, but we are mandated to do ABC. By the time we get approval that we should do central posting, then it becomes a mandate because that's what the Act says. If there is something that is not in the Act that minister says you should do, is part of now your mandate, even though it's not in the Act. So I said that. So sincerely, be very happy when we get issues like this. It's not part of our mandate to determine what should be paid to interns. Maybe we can be able to create some place in the accreditation guidelines to say that that is important because it's going to make them to be able to settle and do things, something like that. So if we put it, then that's when we'll now be able to say we have a regulation, we have a law that mandates us to do that, and therefore we can be able to enforce. But without anything like that, enforcement will be difficult. But as I've said, we take many things. WHO Rehabilitation 2030 initiative, it's not our responsibility, but because in the ministry there is no department or division on rehabilitation, we are doing that. And a number of other things. In fact, report, petitions to minister, this is not their responsibility. They shouldn't do it. And I keep saying, please, can someone, please, I beg you, can someone take this responsibility and do it so that we don't have to do it? Let's focus on regulation. Since everyone is complaining the regulation is not strong, let's just not do any other thing. Let's focus on the regulation. But the moment you focus on that, I keep saying that you can't regulate what doesn't exist. So if people need to get places, you are going for PPP. Someone just said it's not your responsibility. So it's fine. Let someone do it. Young ones don't have job. Complain. They don't have job. They don't have job. They don't have job. What are we doing to provide the job? So if nothing is done and the board takes it, now it's a complaint that board. So I'm not complaining, but what I'm trying to say is that I agree we should take it up, and I assure you, I've written it down, and we are going to see how we can support these young girls to ensure that they get paid properly. But I just want to plead also, just like Mr. Adefarakan said, I should go and see the minister and tell him this is what physiotherapists say. I said, help me also now. Let's go together. And that's why I said, let me call for a meeting between the ministry and the professionals. You are an elder. The way you speak eloquently here, I want you to see you speaking also eloquently to the minister. I will coordinate, I will bring the meeting. And I told you how I argued with the former Minister of State. I've done my own part. Let someone also support me. Let someone help me so that the load will not be too much on my head and break my neck. Please, I beg you, please. I'll get Adefarakan. Let's discuss so that we go to see the minister together. All of the people that are eloquent have these voices. Let's go. But I assure you, I will not stop taking things, even if they are not within our mandate. In as much as it's going to help the professionals, I'm going to take it. And I will do what I can to the extent that I can be able to do it. Thank you very much.
Yeah,
Thank you so much, Prof.
Thank you, sir.
Prof,
yeah.
You know, I'm ready to follow you anywhere, not today. We have been to many places together. I've been a partner in progress with you. So I don't have an issue. Anytime you called me, this is not the first time. Anytime you call me, I'm ready to, give you a support. And sorry, on the issue of a National Assembly, let me before registrar, let me give you the background of what happened in that place, because I'm familiar with, with what is happening there. Before National Assembly, they take physiotherapy, doctor, interns, copper, and all the supporting whatever staff they take. But what happened along the line is that they now discover the huge amount of money that was going into, the salary and logistics of both doctor, interns, and copper, and all of them like that. So what really happened is that because it's free, they bring people the pay. A Senate leader can send the name of 20 people. And all the senators, they now bombarded that place with name. And there's no way, because I have interaction with them, because my daughter went to do something and they said they cannot pay. So that was the reason why they now stop everything, both internship, copper, and all of them. They stop it for some time. And when the court came again, and the medical people met with the Senate leaders, what they told them is that, look, we cannot afford, yes, if you want them to come, they will come. But it has to be on, no salary. But what happened is that some of the people that now brought their own, their constituency, their whatever, to come and work there, whether as an intern and whatever. So the senator, they are now the one giving those people, stipends, transportation. And some of the departments too, you understand, from their little whatever, where the little money allocated to them, they give these people little money. And it's not only in a National Assembly. Many hospitals, some people will sign that we want to work here. It has happened in National Hospital before. I know so many of physiotherapy that work there without collecting 1 naira for this thing. It's a matter of choice. But I agree, if the board will, should come out with, a petition to them that this is the, that we cannot expect somebody 6 years, 1 year after service, you are now coming again, and they say you should come and do a free service. In fact, I was offered a free service first when I finished in National Hospital, and I rejected it. I said, no, I cannot do that. And I left from there. I went to Kano. So number one is a matter of choice, but the board can come out, since they are the one that regulate it, they can come out, but that is just the background of why, that policy is still working in the National Assembly. Thank you very much.
Thank you so much, Dr. Adebango. Thank you so much, sir. We appreciate you for that insight. Prof, we have some questions on the YouTube chat. I'm going to read them out for you. One, are there unique requirements or special considerations given for license renewal for COP members immediately post NYSC? Are there unique requirements or special considerations given for license renewal for COP members immediately post NYSC? A student is asking that, is there any hope on making more internship slots? Because internship also is a worry for us as students. And why can't NLTB do central placement? Okay, I think this has been answered initially. Divine Jude, the registrar has said quite a lot concerning internship and central placement. So you will get the brief of the whole meeting. After the meeting, there will be a communique sent out to all any career officers. There's a question also about DPT certification for license renewal. Is there a way that DPT certification can be used for license renewal? Registrar, you have the floor, sir.
So DPT for license. So number one, there is no special NYSC requirements. The time you finish your internship, get your full license. Don't need to give CPD to get the full license at that point. From that point going forward, everything is the same every year. So you finish your NYSC, you're just renewing the professional license. So it's no special NYSC. But if there's another context you are looking at it from, let me know so that I'll be able to see if what you mean is different from what I'm trying to say. Is there hope on making more internship slots? I think I've mentioned a lot of this. Just like you said, you can give him information. DPT for license renewal. Now, the way this thing works, and people don't understand. That's why people kept accusing the board. Board is doing CPD and everyone is being forced to do it. Wherever you go and do your CPD, in as much as it covers the domain that we are looking for, you are cleared. The only thing is that you can't just give us admission letter, because that's what many people do. You give us admission letter and you say 1 year, it covers 30 CPD. In the past, they did that. But me, I'm in the academia. I know you can get admission and you don't even go to the school. You just keep the admission and therefore we tell people, bring a transcript that shows in that year that you want to renew, these are the courses you have taken. Or if you can't get a transcript, go to your department. Let the department write a letter, or maybe your course coordinator with the letterhead paper of the institution, something formal that so person is currently or has taken at this period, so course that is this hours or this CPD, this credit unit, and give you information, sign, then you bring it and that will be used. So for 1 year, your DPT can serve for 30 CPD in as much as you have covered those 30 hours that gives 30 CPD. But if you are renewing for 2 years, then the course content must be submitted to indicate that you have covered all the 4 different domains that you are required. Evidence that you have done hands-on that for at least 15 CPD points, the theory, this one I know, if you are doing DPT, there should be evidence there. But is there any course on management? Is there any course on this, on that, research and all that? You can be able to renew your license with that. And the same thing, people that do presentations in their departments, but not interns presenting, because this is CPD that someone is teaching you. Unless if you are taking it that the interns are teaching you, then you can include that with their profile. Let's see. But if that's not the case, then staff presenting 1 hour or 2 hours in a week, all you need to do is to apply to the board. For the next 6 months, we have planned to do this course, these presentations, and then the profile of those presenting, we can give you approval. Say you have 10 CPD points. So all these are possible. So the only things that we don't encourage, for example, diaspora, someone will use one phone here, one phone, maybe use their computer, they snap picture of the course that they have taken and say, Hapa. If I'm going to apply for HCPC license or US, am I going to screenshot my, initially we said, okay, let's see how we can help you. But then later I realized we shouldn't really make the board look like it's not serious, that you just take screenshot from one phone to another and you send and their license is renewed. I think we need to that, and that's one of the reasons that those in diaspora have been having delays in renewal license. But we have gotten an organization that wants to start helping us with verification of CPDs. The moment we sign an MOU with them, we just say, okay, go through them. They will verify and they will link their own portal to our own portal so that wherever you are, whatever CPD you do, if they clear it, it just manifests on the portal. So thank you.
Thank you so much, thank you so much. If I understand, I just want to get clarification on the DPT thing. I think the person that asked the question is asking from the perspective of people who are doing masters currently and how most of them will not need to submit certificates for certain CPD categories just because the program which they are doing covers for that. The same way, does it apply to people who are currently doing DPT programs in, let's say, Unilag, University of Wesley, University of Unimed also?
The answer is yes.
Okay.
Why? Because when you have a BPT, a transitional DPT is an upgrade. It has additional things that you did not do in the BPT. And that is what CPD is all about. That's why it says continuous professional development. If you do DPT or transitional DPT, you are developing yourself. You are going a little bit higher than what you have known. You are developing yourself. So it's a yes. Straightforward, it's a yes. You do transitional DPT in the year that you're supposed to present evidence. Don't just give us admission letter. Give us a transcript or a letter from your department saying you are on the program or you have done the program in so period.
Okay, thank you so much, Prof. There is a complaint of a copper currently on the YouTube chat she said that she's a copper in Nasarawa Lafayette and there are no hands-on trainings that she can go for. And the only one close enough is at Kefi and Abuja. And traveling as a core member is a long thing as they would need approval and all. And there are domains for each of these CPDs. So the only hope of she having a complete CPD for each of those domains, CPD for each of those domains, she's just trying to find what can be done for coppers who are in this particular category where they do not actually have access to some certain domains that is being needed for license renewal.
See, if you introduce a policy, before it starts to work, you must produce a way for people to be able to fulfill the requirements of that policy. Sincerely, this was the reason why we started to do CPD in the board. See that it's not about money because it's say 1,500. Just so that let everyone do it and fulfill the requirement, because we are the ones that say this is the policy. You must do the CPD before clear. But people reported to minister. Minister said, this is in the act. I know it's in the act, but please, just hand it over. Let them do. So NSP was the one that reported. You are a member of NSP, I believe. If you are not, whatever association you have, go to them. Let them know. Let them help you. Because anything I say right now, it will be to the minister. That Rufai is the one suggesting where to go to, because they said there is conflict of interest. I should stop Institute. I say, no problem. I've stopped. So wherever I tell you to go now, someone is going to report to minister that I have conflict of interest. So me, I've hands off this thing. I'm sorry, I should help you. I shouldn't say this. Sincerely, I know it's a mistake to say this, but I just understand that wherever I tell you to go to, tomorrow is going to be an OGM matter discussed, conflict of interest. So, but let me forget that and apologize. I've even said that. But I think there are, ask the associations. You complain that you are here, let them provide some ways that they can organize something there. I know there are ways that we can solve this, but my mouth is tied. I can't be able to say anything right now because of the current situation. Thank you very much.
Thank you so much, Prof. Thank you for the answers to all questions and all comments. Thank you so much. Someone is asking that the 20 institutions that have been asked to start physiotherapy or other rehabilitation professionals, are they under MRTB? And also the issue of the
Sorry,
MOU,
come again. The institution that were asked to start what?
Yeah, there was a time you were saying something about some 20 institutions that have been asked to start physiotherapy and some other rehabilitation professionals. Are they under MRTBN? That is one. And also the time that you said something about MOU, is asking that are these MOU, are they free, and would it affect the next registrar of the board in case when your tenure ends and another person comes up to be the registrar?
Okay, number one, you know, universities, they are under NUC and then under Ministry of Education, and the minister mandated them to start. But of course, when they get approval from NUC, they must go and seek for accreditation. And the minister made it very, very, in fact, in the letter they were given, we are under Ministry of Health, but the Minister of Education, in the letter given to the committee, instead of making MRTB member of the committee, he said they should report to him through MRTB. That's what the letter read. I saw the letter. So he wanted to emphasize to them that it's very important. And at each of the meetings, he will point at me. He said, they will guide you. They will guide you to put in place what is required so that when they finish, they will practice and all that. So they are not under the board, but they must come for accreditation and regulation before they produce their reports. And that the minister has emphasized to them. In fact, he told them, he said, I worked with him, Ministry of Health. Therefore, go to their board, do this. Even today, they reached out to me, wanted information that some universities need. Yes, so that's number one. Number two, sorry, my friend is reduced, his function is being reduced. What's number two?
That is about MOU, sir.
Okay, see, this is something that the ministry has owned. Minister is very, very much interested in this. That is why I keep saying, if physiotherapists are not interested, no problem. Let's focus on those that are interested. Because the other professions, they are interested and they are happy. They have told us problems, but they said, this is how we can consider the problems. And that's one thing about some of these professions. They sit down with their problems. It's just about, okay, how do we go around it and move forward? But sincerely, I can't say a lot of that about my own profession. It's going to be a lot of things on social media. So, but that notwithstanding, if we agree to this, as I've said, it's not our mandate. Me, it's just because of all these complaints about not having job, that I proposed that to the ministry. So the ministry has owned this. The hospitals are under the ministry. The division of PPP in the ministry has owned this. The minister is interested. And the MOU that will be developed, it is the ministry that proposed the person that will develop the MOU. The only thing is that you must pay them. And therefore, we took the responsibility of looking for funds. And we have a foundation that has agreed, apart from giving 3 million that I've said earlier, to give those that have developed proposal 100,000, they also are going to take care of the funds, the consultant to develop it. It will be in the ministry. If registrar leaves, nothing affects what will continue to happen, because the PPP division in the ministry will still continue to be there. Minister's directive will be there even if the minister has left. So this can be institutionalized. The only thing is just declaration. We want this. We don't want this. Want it? Tell them. Don't want it? I'll just let them manipulate and just tell them that, look, almost every hospital that is owned by the federal government has physiotherapists. So we don't need that for physiotherapy. But for occupational therapy, speech therapy, audiology, prosthetics, and orthotics, they are just there in only very few hospitals. Let's consider them. So I think I'll leave it to the physios. This is where majority will be. And I assure you, if the majority say no, what is my witness? Will error.
Okay, thank you so much, sir. I think we are done with all questions on the YouTube channels. Yes. Do we have anybody else with any question, comment before we bring the meeting to a close? It's been a long night. Okay, in the absence of none, I would like Zakia Al-Azan to please give us a closing prayer. While he is preparing for that, I just want to appreciate the registrar, Teresa Rufai, for giving us his time this night, for addressing all our concerns, shedding more light onto all issues that have been raised so far so good, and for doing his best to see that we are all carried along. Communication is very, very important, and information is key. And we've gotten a good number of this night for this interaction that we've had. Thank you so much, sir. Thank you for honoring our call. Thank you. We are still going to call you once again. We've listened to you. You've told us what to do. We will go and sit back and get some of these things that you've requested for, and then we would reach out to you with our suggestions, with our statistics and everything, sir. We really appreciate it. Thank you for your time, sir. We do not take it for granted, because we know that the next time we call you, we will also answer us.
Thank
to
you. Thank you.
Early and young career physios who have been here this night up to this present time, you should be sleeping on your sweet bed by now, but you stayed till the end of the meeting. I give you all 5 stars. Kudos to you all. Thank you so much for staying through. Thank you so much for coming for the meeting. We do not take anyone's presence for granted. Thank you, thank you, thank you. I don't know if Dr. Nnamdi Eze, our coordinator, has one or two things to say before PT Zakia Al-Azan gives us a closing prayer. Dr. Nnamdi. Okay, I don't think he's still on the call. I also want to appreciate all members of the Early Career Doc Committee, Dr. Williams, the Secretary, Dr. Divine Favor, Dr. Oxford, Dr. Adedayo, Dr. Bello, Dr. Aminat Abolade. We say a big thank you to you all for steering both of this early career group. Yeah, we should close the meeting right away. It is Zakia Alazan. Please, can you give us a closing prayer if you're still there? Zakia Alazan, can you give us a closing prayer? Maybe he has slept off. Okay. The move pastor, can you give us closing prayer? Okay, we can't hear from them. Hafiz Mohammed Nasir, can you give us a closing prayer, sir? Wow, since people have slept off, it's well. All right, I'll just do justice to that. Heavenly Father, we thank you for a very beautiful meeting tonight. Thank you for exposing our self to light. Thank you for giving us light on certain matters. We say that you wanted in Jesus' name. Lord, we hand over to trap into your hands that you help us to steer it, help our future be protected, help us to make good decisions, right decisions as at when due in the name of Jesus. Thank you all. Thank you all. Thank you all. Good night, everybody. Good night. Bye bye. I hereby declare this meeting closed.
Yeah, good night, everyone.
Good night.
Good night.